Gathering of Seagulls, highlighting EMS advances from America's premier peninsula. In this comprehensive session, a sampling of EMS medical directors from around the state will gather to discuss their latest research, quality improvement initiatives, concerns, and future vision for out-of-hospital care in Florida and beyond. All speakers have no disclosures to report. Today's hosts include Dr. Paul Pepe, Florida State EMS Medical Director Dr. Ken Shefke, and President of the Florida Association of EMS Medical Directors, Dr. Christine Van Dillen. Topics in today's session include the following, as well as the following. Our first topic will be a heads up on Heads Up CPR, implementing the life-saving advance in the Sunshine State by Dr. Carrie Batista out of St. Johns County.
Hi, my name is Carrie Batista from St. Johns County Fire Rescue, and we're going to be talking about Heads Up CPR. First off, disclosures, none. So some of you may have seen a presentation I've given about our experience changing how we treat cardiac arrest over the past 3 years. Out of this, we've implemented a bundle of care for all of our cardiac arrest patients. And historically, this is where we were, roughly 160 to 180 cardiac arrests per year, with 3 to 5 patients being discharged neurologically intact from the hospital. And these are the things that we changed. We went to a no-go policy out of the comm center. We developed a bundle protocol with pit crew style CPR, active compression, decompression CPR, and impedance threshold device for all of our cardiac arrests. We focused on the BLS portions of the CPR algorithm. We overall worked on a goal-driven process for cardiac arrest. We participate in the CARES network. We follow our data for outcomes, and we'll do some minor course corrections based on that data. By making these changes, we more than doubled our baseline ROSC rate over the past couple of years. In 2018, we more than tripled our neurologically intact discharge from the hospital with CPC scores of 1 and 2, with 17 patients discharged from the hospital. And in 2019, we continued that trend with 19 patients being discharged with CPC scores of 1 and 2. So now we look at what's next. How can we squeeze more juice from the system? So let's talk about Heads Up CPR. So what's the optimal position of the head and the heart during cardiac arrest? A is what we're used to, but B and C have been looked at. In standard CPR, each time you press on the chest, you're causing a simultaneous arterial and venous pressure wave, which is then transmitted up to the brain. And if you look at normal physiology, your intracranial pressure fluctuates with cardiac output. With standard CPR, the ICP can rise to abnormal levels and cause damage. With active compression, decompression CPR, plus an impedance threshold device and heads up physiology, you mimic that normal physiologic levels. Heads up CPR causes venous blood to drain from the brain. It causes lower ICP. It reduces that concussion with every compression. It enhances your right to left heart circulation, and it doubles the blood flow to the brain versus just flat active compression, decompression CPR with the impedance threshold device. So looking at pressure tracings from animal studies, you can see aortic pressure tracing stay the same, but with a 30-degree down position, your intracranial pressure increases and your cerebral perfusion pressure decreases. And this is the opposite of what you're trying to achieve for good neurologic outcomes. With heads up positioning, you can see your intracranial pressure comes down to near normal levels and your cerebral perfusion pressure increases. So how high do you need to raise the head? Turns out about 30 degrees is where you need to be for normal intracranial pressures. Anything more than that, you'll actually have decreased pressures, and anything less than that, you actually wind up having more congestion and increased pressures. So how to raise the head is important. If you just raise the head up and keep the body flat, over time the blood will pool in the feet, and that decreases the blood volume that's available to come back and circulate through the head and the heart. If you just raise the head up, the angle is severe and it's harder to get the blood up to the head. If you do a more gentle slope, it allows for lower right atrial pressure, higher cerebral perfusion pressure, higher coronary perfusion pressures, and it preserves that central volume. So looking at cerebral perfusion pressures with different styles of CPR, you can see at the bottom, conventional CPR causes decreasing pressure over time. Conventional CPR with heads-up positioning is better, but it also decreases over time. Active compression decompression with an impedance threshold device flat works better, but it's the combination of all three that gives you the best physiologic cerebral perfusion pressures. So it turns out the time it takes to get to the elevation is important as well. 2 minutes seems to be about optimal. Slower time than that seems to lag, and faster actually had the worst pressure as you lose that forward pressure head of the fluid is lost. So recent animal studies showed a slow controlled elevation sequence provide near normal cerebral perfusion pressures. Pig survival study showed 6-fold increase in neurologically intact survival with elevated active decompression CPR versus conventional. Hemodynamically, end-tidal CO2 and cerebral oximetry monitoring was increased with heads-up CPR, and there were no observed safety issues. A recent study from NAMSP last year showed overall improved hemodynamics in a heads-up positioning. Diastolic aortic pressure, coronary perfusion pressure, end-tidal CO2, and cerebral oximetry all were better with heads-up positioning. So there is a device out there which will accomplish this optimal positioning. It's the only one that I'm aware of. It's called the EliGuard. It works with the Lucas. It can be integrated into an already existing plan of care. It's a small board that's placed under the patient with a Lucas backplate on it. You hit a button, and over 2 minutes, it slowly raises the body up to appropriate positioning. It's been utilized in several small pre-hospital studies so far. In Minnesota, they found increased ROSC, increased overall survival, and increased good CPC scores at discharge. It was rolled out in a small study in Palm Beach last year and also showed increasing survival to admission. So what are the do's and the don'ts for heads-up CPR? First off, what is essential? You have to prime the system with high-quality CPR and an impedance threshold device for a couple of minutes before you elevate the head and the heart. This starts circulation before you elevating the head. You have to use an impedance threshold device. Multiple pig studies have shown that without it, the aortic pressure falls, and there's just not enough forward circulation to keep flowing to the brain. You have to elevate the head slowly, not rapidly, or you'll bottom out that aortic pressure head. And what's wrong? What are the don'ts? Rapid head elevation, especially without priming the system with CPR in a flat position, is bad. It's like when you get up too quickly, you bottom out your blood pressure. We might think that elevating the legs might be a good thing, but the increase in venous blood and pressure goes directly via the veins to the brain and increases the ICP, which is just what we're trying to avoid. Keeping the legs down and the head up by, let's say, elevating the whole body on the stretcher, over time, the blood will flow downhill due to gravity, pool in the legs, and you don't have enough to circulate to the head and the heart. When using the Lucas, you want to make sure it doesn't migrate. That can cause harm, and you don't want to elevate the head or the heart too high. So what is the optimal cardiac arrest protocol to increase all patient survival? As we study this physiology more, we may be looking at integrating multiple techniques and positions to mimic normal physiology as best we can while we try to get the heart restarted. This may involve new ways at looking at what we do and how we do it. Also, how we integrate these techniques into our pre-hospital skill set. I think that overall, this can be accomplished, and we can increase our cardiac arrest survival even further. I want to thank you for your time, and I look forward to talking to you all soon.
But we just wanted to make sure that you do understand a couple of things. We had Carrie Bachisa was here just earlier to get on with us and take some questions. One of the things I think we really need to point out is that the issue he made about that this is part of a bundle. It can't be just done by itself, and it has to be done in a very methodical way. It can really improve outcomes, but you got to do it in that bundled approach. It's dependent on the other components. Period of time in terms of cerebral perfusion pressure, then going up to head up a little bit better, but then that falls off. And then it goes up to the active compression decompression, or like a Lucas device, and the ITD. That was really clearly better. But when you add it all together, it's actually synergistic. It's not just additive. And that's what we saw, Ken, in Palm Beach when you introduced it as you went station to station. It was profound. And we thought, well, maybe we did training, we did some other things that improved the outcomes, but this was just really compelling data that you found in Palm Beach County, right?
Oh, it's absolutely right. And I think it makes good sense from just like a hemodynamic sort of a thing. It's really just like pumping fluid, right? It's fluid dynamics thing. When you increase the pressure and decrease the resistance to flow, you get better blood flow to the brain. So it's all about increasing stroke volume with active compression decompression, making sure that the vacuum on the upswing of CPR is being used to bring in blood as opposed to bringing in air. So you sort of seal off that air leak with the impedance threshold device, and then slowly raising the head so you can drain the venous congestion out of the brain is the key.
So I think the paying attention to the details, what he brought up was the issue of, the pit crew approach. It has to be done very efficiently, effectively, and done timed just right. And I think that's what you were able to accomplish in your area. And some of the things you learned as you did that was actually, like, for example, not to interrupt CPR too much, putting a machine on. And so you've even produced videos where you can show how you can efficiently get that done within 5 seconds. And I guess the point I'm trying to make is that as you see this going around today, as we go to the different talks, is that it doesn't end here today. If you want to get follow-up, touch bases with us, we'll tell you how to get it done better. We have some tools because we've had some experience. And it also, this emphasizes that Florida is taking a lead again in this area, and it's just really exciting. And then, Chrissy, after seeing that, how do you feel about this? Are you going to do something like this in your own system?
Yes, actually, when we cut off, I was just asking Kerry for his protocols because I think this is something that we could potentially implement. And I'm always open for new ideas. And I think that that's the great thing about being a medical director is we can initiate changes to improve patient care pretty easily, but I think we have to do it carefully, and we have the experience of other people, which is great about this forum right now today.
Yeah, and that's the thing to emphasize is that this isn't about telling you, trying to convince you to do this. In fact, we insist that you don't do it unless you do it right, and that's key to pay attention. All right, we better move on to other speakers. Now, one of the reasons why this has been so helpful, particularly the use of mechanical CPR devices, and when we added it up in terms of amortizing the amount of additional equipment you have to do and what it might cost as you do this is actually not that much when you compare it to the overall cost of running an ambulance every year. But one of the reasons we do it for is that we can get people into the hospital or catheterization, or if they're in refractory VF, that we got to get them there, that we can buy time and maybe get them to ECMO. So one of the persons in our community who's done a great job in this particular area has been Desmond Fitzpatrick out of Lake County, where they've actually set up protocols and for not only resuscitation centers, but also for ECMO specifically. And he'll tell you more about that. Chrissy, you know him better than anybody, I guess, here. Can you tell us a little bit about Desmond?
Yes, Desmond Fitzpatrick is currently the medical director, as you stated, for Lake County EMS, Lake Technical College Paramedic Program, Sumter County EMS, and faculty at the University of Florida. He's also the associate director of the EMS Fellowship and helps educate residents and medical students about EMS. He's an amazing individual, the epitome of a Irish Catholic, born and raised in Miami. So he's an amazing person, has a great heart, and is always there to help. And so he was actually he was, I think, my second round of fellows at the University of Florida for EMS, and he's near and dear to my heart. So I'm very proud that he's initiating such great things there in Lake County.
Okay, so actually, I'm actually an Irish citizen myself, so I've been very glad to introduce Mr. Fitzpatrick. So we'll have him on this morning. So let's go ahead and turn it over without further ado. Let's hear what Desmond has to say about using ECMO, as I call it, extracorporeal activities in the pre-hospital setting. Go ahead, hit the video.
Hello, my name is Desmond Fitzpatrick. I'm faculty at the University of Florida and medical director for Lake County's EMS system and Sumter County's EMS system. What I'd like to talk to you today about is the development of a pre-hospital ECMO or eCPR program. We'll briefly go over the different types, what other places have done, and I'll walk you through some steps on how you may be able to develop this in your system. What is ECMO, and what's the difference between ECMO and eCPR? ECMO is extracorporeal, out of the body, membrane oxygenation. When we're doing that on a patient in cardiac arrest, it's called eCPR, basically ECMO in cardiac arrest. It uses a pump and an oxygenator to move blood out, oxygenate it, kind of like what your lungs would do, and move it back in. Two different types, not super important for this, but basically VV bypasses the lungs, and VA bypasses the heart and lungs, and VA is what's used for eCPR. Here's a quick infographic just showing basically the blood is being taken out, goes through a pump, gets oxygenated, and put back in. There are two main types of pre-hospital eCPR ECMO programs. There's the pre-hospital eCPR ECMO team, like in Paris or Albuquerque, where basically they bring the physicians, the teams, the ECMO machines to you. And then there's ED or ICU-based eCPR, which is done usually with pre-hospital involvement with the development of a process or an alert, much like a STEMI alert. Quick pros and cons of each. So with the field eCPR, it brings the hospital resources to the patient. It can have shorter time to ECMO, but it can be really costly, resource intensive, and it's based on the availability of the personnel. Difficult without a lot of funding to do 24/7. ED base, you bring the patient to the hospital. You can have more consistent coverage because it's the hospital resources. Sometimes you'll have longer time windows, and you require the resources to already be available at the hospital. While the Paris Mobile ICU may be the most famous, we have two different programs in the U.S. that I'd like to quickly talk about. Albuquerque's, it's a low-cost program. They actually use a hand crank ECMO device, a lot cheaper. It's based on volunteers, lower cost, lower volumes, and they actually have crews crank the device. Minimal outcomes so far. Minneapolis is gearing up to build a ground-up program, really costly and resource-intensive. They got a $5 million grant to do very similar to what Paris is doing, and basically bring a mobile ECMO cath lab to the patient. While a mobile ICU or mobile cath lab ECMO program would be ideal, it's very costly. So the ED or ICU-based ECMO program is most reasonable for systems. It's most likely to be able to launch within a reasonable time. It can be run by the ED alone. However, it makes a lot of sense to partner with local EMS to develop pre-hospital screening and pre-hospital alerts. It's the area with the most outcome data, and the data has been very positive. I'm going to breeze through the next few slides just so that we can make sure we get through on time. Basically, the pre-hospital eCPR alert has happened across the U.S., most famously with Dr. Tana out of Utah. There's a couple other programs there, and this was recently launched in Lake County as well. Unfortunately, it's been paused due to COVID. You may ask, where do I start, or how can I do this in my community? So we'll briefly go through the checklist, and then we'll do it in more detail in a second. You need to have an ECMO program, or the hospital needs to be starting an ECMO program pretty shortly. You should have buy-in from the local hospital, ICU, CT surgeon, and ED. You must define your scope, whether it's going to be during daytime or 24/7, and your catchment area. And you need to define your patient selection. An established alert process based on the selection with an established response agreement with the EMS and the ED makes a lot of sense as well. So step 1, identify your resources. You can't do it alone or without an ECMO program. Step 2, develop partnerships. You got to make sure that the hospital is bought in and that you have developed people who are really involved and committed to this program. Step 3, identify a scope. Have realistic discussions about what you can do, time period, and your catchment area. Lastly would be meet with all the players to decide what the patient selection criteria is and how you're going to work your alert process. Dr. Tana has done a bunch of work already, so I will show you some of the resources you can use on the next few slides. Here's his alert criteria. Pause if you need to look at it. And he gives you sample flow process for how you can get this done. This is another great reference if you need to pause. In Lake, our partner hospital, Advent Health, expanded the criteria a little bit more. Here they are for your sample. Here's our agreed upon exclusion criteria. Here's our sample alert form. As you see, we still work the code on scene for at least 10 minutes unless a mechanical CPR device is available. 3 quick trials show some pretty good evidence on this. The Shen trial, number 1. The Save J trial, number 2. And then here's the Cheer trial for you guys to reference. I know that probably felt like a whirlwind, but please, if you have any questions on how you might do this in your system, reach out. Have a good day.
Well, that's fantastic. And I think that's another example of how people in this state are taking a leadership role, rolling things out. And it's really great to hear what Desmond had to say. And he actually did a good job of getting us on top of what's really happening out there in the rest of the world, and from New Mexico to Minneapolis, et cetera, in Paris. And so we're staying on top of that has really been very, very, very useful. So anyways, Ken, part of what he brought up is something near and dear to you because of your whole concept of starting official like resuscitation centers, like we have trauma centers or comprehensive stroke centers. Do you agree?
Yeah, absolutely. So I think EMS has been a real leader in the field of cardiac arrest resuscitation, and we've sort of been doing a lot of newer things, including the head of CPR that we just heard from Dr. Batista. And now when we get into this field where we know that we can do better CPR in the field that keeps the brain cells alive longer, and these folks just need additional support, really an eCPR program, it makes the most next sense. So having resuscitation centers that are doing all the latest and greatest, such as taking these intractable V-fibs to the cath lab, taking cases that we think the body is viable, but we just can't get the pump going yet, but we've done such a good job pre-hospital with.
So that was terrific. And I think what's really cool is that we're not only bringing things in from the rest of the world, such as you heard from Paris, from New Mexico, et cetera, but we're actually doing a lot of this right here and now. And I think one of the take-home points for me here is something that Florida was already doing a few years ago, particularly in Palm Beach County, where they started looking at setting up resuscitation centers. So you knew reliably this is a place that's ready to do, whether it's ECMO or doing cardiac cath or whatever, and helping with or temperature management, that you can have the reliability that your patient's going to get the best outcomes because they have a place that's reliably doing these things and setting it up. Ken, you have a leadership role there in setting up. I assume you agree with that concept and the take home from the ECMO one?
Oh, absolutely. I think EMS has been a real leader in out-of-hospital cardiac arrest, and we've been pushing our hospitals to recognize, hey, there's been some major breakthroughs in the science, and we're not just bringing you a dead patient anymore. Even if we don't get pulses back, we've done such a good job with advancing, getting good brain blood flow, like we saw in some of the other talks, that even if we don't have ROSC, these people are still potentially viable. And if we just do some extra stuff like bring them to the cath lab or put them on ECMO, we can get a patient to walk out of the hospital again.
Yeah. Hey, there's a person that's live on this thing, MJ. If you could mute yourself, I'd really appreciate it. Everybody else who's on this live, please do the mute. I would really appreciate it. Hey, so, all right. Well, and then Chrissy, do you agree with this idea that maybe it's something we should explore throughout the whole state? I think there are some other states exploring this right now.
Absolutely. I think this is a positive change in the right direction. I think we have a lot of opportunity to take potentially viable patients and get them to the cath lab. And I think with Dr. Shebke's leadership at the state, we can maybe utilize that role to open up this opportunity through the resuscitation centers and allowing that data to maybe not be utilized in a negative fashion towards cardiologists.
And I remember the day when we were just trying to convince people that a stroke was worth looking at, and paying attention to. And then within a few years, it became a joint commission requirement. So I think we can make that happen here. And we've done a good job, as you'll hear later in this broadcast, that the stroke center leadership here in this state has been fantastic and has made a tremendous difference in outcomes. So we'll see how that all goes. So I guess we need to move this along, get to the next talk. And again, part of this whole thing is to highlight what's going on in the state of Florida and the leadership roles we've taken. And one major breakthrough has been in the arena of pediatric cardiac arrest. And I think that this is what you're about to hear is a study that was published this past year in Resuscitation, a big scientific journal, high impact. It was published out of Polk County, Florida. And the leader in that area was Dr. Paul Banerjee, who really helped bring this thing along incredible and got survival rates for kids that in the past was dismal outcomes in the pre-hospital arena for some good reasons, by the way. But now that he attacked those reasons and really got into it, he and the crew there did a fantastic job. Heiko, if you're live, I have to turn off. Okay, thank you. So anyways, with that, so anyways, Dr. Paul Banerjee, if you don't know him, is the medical director for Polk County, and he works with some terrific people there. The chiefs have been just really progressive and so on. And you know him fairly well, correct, Chrissy? Can you want to say a few things about Paul?
Yes. Dr. Banerjee, has had a very active role locally in EMS and is always out for new adventures. And he is a neighbor of mine. As I'm in Osseo County, he is in Polk. And we do have a rodeo day where we have bulls in the streets in Osceola County. And I think that Polk County might have a similar addition, but they have the gators in the streets. I don't know. Maybe he can tell us that story at a later time.
Yeah, and again, Paul's just a recognized
discussion about what you can do, time period in your catchment area.
I don't know who that is that's live, but you're live. And we're going to ask everybody to please mute themselves because that's not fair to the speakers here. Thank you so much. Hey, so I do want to say about Paul is that Paul's been recognized, not only here locally in Florida as the State Medical Director of the Year, but also nationally. A few years ago, the Journal of Emergency Medical Services named him the Innovator of the Year. And here's the reason why. So without further ado, I'd like to bring on Dr. Paul Banerjee to talk to us about the concept of what I call the Polk County POCA being pre-hospital,
pediatric
out-of-hospital cardiac arrest, and how to achieve neuro intact outcomes after pediatric cardiac arrest. There you go.
Good morning. Today we're going to talk about pediatric out-of-hospital cardiac arrest and talk about our survivals that has improved significantly from 0 to more than 45% survival rate in pediatric resuscitation. These are numbers that we never thought we would achieve, but through small changes and a couple of big changes, we're able to make a big difference in the lives of kids in Polk County. So when we look at pediatric arrest, what comes to mind? Usually people feel uncomfortable is performing life-saving tasks because we're okay with adults, but we don't do enough with pediatrics. There's an emotional impacts of the potential loss of lives of a child's life because they're so young. We know that good outcomes are rare. So in general, most people are very stressed and basically people panic. So how can we approach this in a better way to get better outcomes? Looking at pediatric and adult resuscitation numbers, and this is the Sudden Cardiac Arrest Foundation, EMS treated overall survival rate for pediatrics is about 5.4%, and in adults it was like 10.4%. So pediatric resuscitation is half as successful as adults. And we understand why it's so difficult because we don't do it enough and we're not very comfortable with it. But then looking at the further aspect of pediatric arrest, kind of looked at why do we fail at pediatric out-of-hospital cardiac arrest. So I kind of looked at the top 10 list like they used to do with Letterman and kind of had a deep dive in seeing why do we fail at this. Well, number one, there's time. So by the time you get there, there's cortical ischemia and brain injury occurs within 9 to 12 minutes. So even if you resuscitate the child, are you going to have just an organ donor? Usually these children have arrest and it's witnessed or unknown downtime, so you don't know how long they've been deceased. Number 3, there's a delayed administration of epinephrine due to traveling, looking up medications, what doses, because we're not comfortable with that with pediatrics. There's poor bystander CPR rates, which is 33%, which is kind of shocking because it's the same as it is in adults. So that was kind of unnerving. The number 1 rhythm is PEA and asystole about 82% of the time, which, in adults, survival rates are under 5% for both. So you're already dealing with a bad outcome in a child that you don't do very often, at the same time in a rhythm that's not very successful. And do we address causes of PEA at the same time? We have very poor training and comfort with pediatric out-of-hospital cardiac arrest. How much time do you really spend on pediatric resuscitation? We do a lot with adults, but maybe we avoid it because we're not comfortable with kids. Pediatric-wise, how many are comfortable intubating children? Poor intubation skills, being that respiratory failure is the number 1 cause of death. We need to be good at intubation or developing a definitive airway. Number 8, once you get the resuscitation, people are very excited, the adrenaline's flowing, and they start hyperventilating and start bagging the patient rapidly, which is, again, one of the things that cause increased mortality. Number 9, what we do is we are uncomfortable on scene, and we used to do the same thing. We take the child away from the scene, take her to the back of the ambulance, start working on them and looking up doses and resuscitation guidelines because we're not comfortable, we don't do it well, and we don't want to look like we don't know what we're doing in front of the family that are probably quite distraught. And also, we're using the same old doctrine of PALS. So I think we've been using PALS forever. The numbers haven't really improved, but we keep doing the same thing. And basically, is there a better way of doing what we do? So in 2012 and 13, we looked at our resuscitation numbers of pediatric arrest. We had 0% survival, so every child died. We don't do it enough. There were like less than 30 cases a year. All the medications required math, and there was an innate stress of pediatrics. It's kind of like the system 2 thinking. It's if you multiply 343 times 842, most people have to look it up with a calculator, so you have to stop and write it down. It wasn't like natural to people to take care of these pediatric arrest patients. We use a length-based tape for years without any increased survival, and obviously we've been using PALS as well. Primarily non-endotracheal airway management was used, bag valve mask, non-rebreather only. We picked them up and started treating them in the back of the ambulance, scoop and run, and we didn't educate our community at all. So we realized that we had to find a way to make changes and improve. So we looked at different aspects of this and found how could we approach this in a different way to make things better. Well, we eliminated the length-based tape and we started using the Hantevi system. We worked patients on scene so there was no scoop and run. We administered epinephrine as early as possible on scene, sometimes under 5 minutes. We transitioned to a definitive airway on scene with under 5 minutes. We had a new PEA protocol that we initiated. We regulated post-resuscitation ventilation rates. We improved training. We make that 4 hours every year, and educated our community as well. And we've had significant improvements in our resuscitation because of this. So the big thing with pediatrics is math. So what if I told you I didn't care what the child weighs? I just want to know how old they are. So this is the system what we went to, which is called the Hantevi system. It was system 1 thinking. If we look at what's 1 + 1, that's 2. That's system 1. We all know what the answers are. Medication doses were simplified. No length-based dosing was required. Integrated directly with our protocols. There's an electronic version that we have as well. And it's almost like a pediatric medical control, which Dr. Hantevi works for us as a consultant. And when we have questions, he'll get back the answer to us within 24 hours. And the nice thing about it, it's very simple. If you look at a hand, anyone who has one can do this system. Your thumb is 1 year old and they weigh 10 kilograms. If you have your index finger, that's 3, that's 15 kilograms. Your middle finger is 5, 20 kilograms. Your ring finger is 7 years old and 25 kilograms, and your little finger is 9 years old and 30 kilograms. So based on the age of the child, you already know how much they weigh, and then you can adjust dosing accordingly. So we stayed on scene. There was no scoop and run. To me, that was malpractice. We wouldn't do it in adult. Why would we do it in children? It delays resuscitation, delays patient care, and kills patients. So we began care, initiated everything on scene right in front of the family. And we stayed on scene for 10 minutes or until ROSC was obtained. The airway management timeline was this. Initially, when they came in, we put them on a nasal cannula, non-rebreather, bag valve mask, but that would only be done for 2 to 3 minutes at a time. Once the saturation was about 95-90%, we'd set up for a iGel or endotracheal intubation, which would be performed within 5 minutes on scene with an additional 5 of PEEP added. And again, if we couldn't get the definitive airway, we also had video laryngoscope, which we can use as well. After resuscitation, we would titrate the oxygen saturation to 94 to 98%. We'd regulate ventilatory rate, having one deep, strong breath and producing one continuous breath every 10 seconds. Post-resuscitation, we would keep the end-tidal CO2 between 45 and 55. And the reason is the number one medication for resuscitation in pediatric arrest is epinephrine. Epinephrine side effect is vasoconstriction. So as it decreases blood flow to the brain, we wanted to find a way to physiologically increase the blood flow to the brain. This was done by increasing your end-tidal CO2, as retaining carbon dioxide will help dilate your vessels in your brain and arteries. We had a PEA protocol that was continuous chest compressions at 100 to 120 per minute, CPR fraction rate of 80%. The transition from passive to a definitive airway with iGel or endotracheal intubation within 5 minutes, hand-heavy dose medications, and with PEA, we try to address all the significant H's and T's that would cause PEA arrest. Obviously, we had ventilate every 10 seconds, IV sodium bicarb based on weight-based and age-based doses, Narcan if they suspected any overdose or opioid overdose, fluids, 20 per kilo bolus. We check sugar, add D10W if the sugar was low. In essence, we would basically be eliminating all the causes of PEA. And this is the buddy badge that they have with the hand-heavy, that based on their age, their weight, and you can decide what dose you need to give. There's nothing to look up. You look at the dose. It's already there. You can pre-fill those. You can actually, what we used to do is pre-fill them prior to arrival on scene because we already knew dispatch would age the patient. We knew how old they were. We knew what dose we needed. We go on scene. No one's having to drop anything. You can actually just administer right as you were there. So our numbers have been pretty successful. As you can see, again, 12 and 13, nobody survived. As of last year, we had 24 arrests. 48% had ROSC. Survival to discharge of those people who had ROSC was 82%, and our overall neurologically intact survival rate was 46% last year. So our crews are doing a phenomenal job. If you have any questions with anything, there's a paper here that you can look up and reference for any things that we've done. It was also done with Dr. Paul Pepe, Dr. Ganti, Rathbatone, and 2 residents we worked with, Dr. Singh and Roka. Otherwise, if there's any questions, feel free to take them. Thank you so much for your attention, and have a great day.
Okay, thank you very much. That was great, Paul. I don't know if you're on with us today because I think you were busy doing something, probably not. But let me make a point that's, I think, really a core here is that one is doing the training that helps you deal with a volatile situation, the verbal judo and so on that goes on was an important part of this study. And secondly, is this issue about the respiratory. He said he made sure that there was lung expansion, there was a good breath, but then didn't give it too often. And the reason why, because of course, positive pressure breaths, if you give too many, inhibit blood flow back into the chest, just the opposite of what Ken was talking about before. During the head-up approach. But you still have to have, if you're doing CPR, you still have to have the lungs expanded so the blood flow can go through your entire lung and not have the lung diffuse, collapse down. What's interesting is that they made sure there's a large lung inflation, but they didn't give too many positive pressure breaths. And I think that was key, because I think in the past we've been told, oh, it's a respiratory problem, so let's give them more oxygen, and that's not the way to do it. Lung inflation is the key thing, but not knocking out cardiac output by too many positive pressure breaths. And we could drill down on that more later, but I think that's an important physiological breakthrough for kids. Yes, it may have been a respiratory cause, but once they're in cardiac arrest, you want to make sure you enhance flow throughout the lung and make sure there's adequate oxygenation going on. That was the first take home I had from this. And then anything else you could really reflect on, Ken, when you saw this study?
I learn something every time Dr. Banerjee gives this talk, and I really like the idea of the permissive hypercapnia, because we're typically doing the opposite when we hyperventilate folks. We're blowing off the CO2 to really low, and you're causing vasoconstriction in the brain. So I love that idea of having a little permissive hypercapnia. It makes tons of sense to me.
Yeah, and I've seen that before in some studies I was doing with hemorrhagic shock a few years ago. We actually found that you got better blood flow through the brain at that point in time. Now, if you have a head injury, that's a little different story. But I think you're right. And then again, you don't want, during CPR, you don't want to have that happening. But once you get blood flow back, it's a terrific idea. So anyway, so good stuff today. And so we heard that one of the key things here was what we call system one thinking, getting, that's the other thing that I can't remember if he mentioned this, but during the talk, what he learned in later years was if he knew it was going to be a 1-year-old, he knew that he's going to, that'd be 0.01 or whatever. So he just, straight 0.1 milligrams, have it prepared. And they were preparing the epinephrine en route. It was a 9-year-old, get 0.5 or whatever it may be. In other words, you knew what you were going to give, and it got it on even faster. And that's part of the whole deal here. And one of the people that really pushed this forward, of course, was Dr. Peter Antebi. And Peter, as you heard through that, has been, again, a national award winner. He was, a year or two ago, he was the medical director of the year for the National Association of EMTs. He's been the state medical director of the year. He's won the Innovator of the Year award from GEMS, and I could go on and on. But what I want to also thank him for is he's known for his background in pediatric emergency medicine and still is a practicing leader down at DiMaggio's Children's Center. But I think also that he's taken a terrific leadership role for the state during this COVID crisis. And I think that's been really a terrific and a great asset to you, Ken, right?
Oh, absolutely. I've worked with Peter for years, and he's literally changed worldwide pediatric resuscitation with his Antebi resuscitation system. In fact, people call him Dr. Hand-Tebi instead of Dr. Antebi because it's so synonymous with his new thing. But yeah, on the COVID thing, yeah, he's really helped organize a lot of medical directors from particularly into southern Florida, but really around the state as well. And we've been having these weekly calls to keep everybody up to date. And he's really spearheaded some of that, which has been really helpful with helping me out at the Emergency Operations Center.
So as we go around the state here and hear these different talks, the initiatives, the publications coming out of the state of Florida, I think that one of the areas that I want you to recognize is that we haven't really even touched on COVID per se. This is all the standard EMS stuff. And one thing that's often ignored, and it shouldn't be, of course, because that's where it all starts, is the dispatch center. And so I actually asked Peter to see if he wouldn't mind give us a little talk about, especially maybe comparing adult and pediatric, things, how they evolve in the dispatch center when the call comes in during those very trying times. So with that, and without further ado, I'd like to introduce the medical director for several systems down in South Florida, including Town of Davie and Parkland, Coral Springs Parkland Fire Department. And then, of course, he's helped us out in various other areas, including Palm Beach, etc. And but want to bring him on and tell us a little bit about what I said here was caring for children with great dispatch. Okay, and so saving lives at the 911 call center. So with that, bring on Dr. Peter Antebi.
Thanks, Dr. Pepe, Dr. Shepke, and Dr. Van Dillen. Hey, everyone, this is Peter Antebi. Let's get to telephone CPR, the nuances between adult and pediatric cases. And just real quick, a disclosure that you won't hear about in this talk. Okay, so first, a big thanks to the team. Of course, Dr. Pepe, Dr. Shepke, Dr. Roach, all played a big part in us really understanding telephone CPR in South Florida, fixing some of the problems that we've seen And that's what this talk is really about. I only have 6 minutes, so let's get it going. And everyone knows that I always put this screen up, which is the out-of-hospital neurointact survival for children has been abysmal for many years. And now we know that part of the reason is because of what happens prior to our arrival on scene. And again, that information that you see on the screen comes from PALS, the guidelines themselves. So really, what are the disparities between the adult and the child? Well, if you think about it, the bystander and the telephone CPR portion of it are very different. And I want to talk about that today in some detail. We're not going to talk about the EMS portion of it, but when you look at children, that part is very different. You have to understand it. You have to know exactly why it's different to understand how to change it. Then we'll start having better outcomes for kids. It's not just what happens on scene. It's what happens prior to our arrival. This study, still very important, from September 2018. Look at what happens when people either get no bystander, they get dispatch-assisted CPR, or CPR just because the person knew they had to do it. Look at the neurointact survival with no CPR from a bystander, telephone CPR, or then CPR because someone there on scene knew what they were doing. You can quadruple your outcomes if you can change what is done prior to your arrival on scene. Very big. And so I was very honored to be part of what they call CPR Lifelinks. You can look this up. This was a NHTSA, Office of EMS, and a National 911 program. It's got a lot of great resources. Let me take you through the importances, and it's all described in this document that you can find online. There are 3 stages of telephone CPR. Number 1, you have to be able to identify it. If you're the call taker, you have to know exactly that, hey, this person is not having a seizure, but they're in cardiac arrest, right? So identification. Number 2, can you give CPR instructions effectively without asking lots of questions? You have to be telling them what to do, right? And the third thing is, once you get them started, how do you continue throughout the call until EMS arrives? These are 3 stages I want to talk about here today. The challenges, you're going to get people at the dispatch that say, we don't have the staffing, or we haven't seen the medical director here in 10 years, or you know what, if we go off script, there's liability, or it's too much money. The scope of practice perception is also a problem. So you're going to have to navigate these waters to fix this problem, just warning you in advance if you haven't done it just yet. So what about identification? So very simple. It's no, go, right? These 2 questions, are they awake? Can you wake them up? And are they breathing normally? That equals cardiac arrest. If the answers to those is no, it's go. Start CPR. It's a very simple concept. What does the American Heart Association say? How fast should you get to this point? It's very quickly. Let's talk about that on the next slide. But if you actually just listen to some audio, you'll see how fast you can get to that. So I won't have you listen to the audio here because I don't have the time. But you can see here just from this screen how quickly this call taker in just a couple of seconds gets onto the green, which is CPR starting. Very, very important. The only way you'll know how you're doing is to measure it, listen to it, fix it, right? So that's what I want to emphasize. The American Heart Association has very easy rules to follow here, right? You have to have those 2 questions within 60 seconds, right? So arrest recognition. Are they awake? Can you wake them up? Are they breathing normally? That should take a minute. And then you have another whole minute to get to hands on chest. Believe me, it's not that easy. And Dr. Roach, Dr. Shepke, Dr. Pepe will tell you this is not easy. We're barely now just at 2 minutes because of all the work that's been done. Okay, so now I want to talk about telephone CPR stage 2, which is CPR instructions. It turns out if you're using priority dispatch, you have options, right? And so the 3 CPR options that you have to determine is 30 to 2 for everyone. Do you want 600 compressions first, then 30 to 2? Or do you want hands only indefinitely? And then there's some options under that. So what have we done? We actually chose hands only indefinitely for 8 years and older. So again, you have to go in there, you have to do the thing, and you have to let them know what you want as the medical director. Now, what's also interesting is that in MPDS, priority dispatch, you're going to get ventilations for these issues: pediatrics, allergic reaction, drowning, and you can see the lists that people are going to be told ventilations first based on the algorithm, right? Understand that. So what are the problems we're seeing? A lot of times the patient can't get flat or they don't want to do ventilations. So you have to be able to kind of quickly get around those issues without waiting for something to just happen, right? This is a coaching thing that has to be done. And, you have to figure out how many chances are we going to give them to get the patient flat before we just say, you know what, don't get them flat, just keep moving ahead. So, we've had cases, again, we've tried to fix the issue in Broward County and in Palm Beach, but we've had some issues we've learned along the way. What is the difference between kids and adults? Well, here it is. Here is a case where you could see that the call taker stayed in the no CPR the entire time. There's a 2-year-old male. It turns out that the mom said in the first 13 seconds, unconscious and not breathing normally, but we never got to starting CPR. Why? Well, it turns out that it's hard for them mentally to start CPR in a child. They don't want to start. That's problem number one. And even though the mom said these things over and over again, we never got one chest compression done on this particular child. That's not a good thing, right? And then when EMS got there, we got the child back to life. But again, this child had 7 minutes of no perfusion to the brain. We know that that's not going to be a good outcome. So how it adds up, no layperson, no telephone CPR, good EMS CPR, child still has a bad outcome, right? Very important to understand that. Let's go into stage 3, which is now the coaching. So you got them started. How do you continue? Well, how do you coach? Good job. Keep going. Count with me. 1, 2, 3, 4. If they stop counting, remind them, I need you to count out loud for me. What about a metronome that can actually be heard audibly through the speakerphone? Coaching is very, very important. You cannot just ignore that. It has to be part of your CQI process. Now, here's exactly a problem, right? Another issue is that when they start CPR, in pediatrics, they'll stop CPR for no apparent reason. And here's a particular case, famous skier, Bodie Miller. He had a daughter who drowned in a pool, and they started great CPR, but as soon as the dad said, I feel a pulse, boom, they said stop. So problem number 1 in kids, they don't want to start. And problem number 2, they will stop immediately for no good reason. And the parent saying, I feel a pulse is not a good reason. So again, just to kind of go through it, in pediatrics, telephone CPR, listen for this. They do not want to start CPR, and then they'll stop prematurely. We can fix this, right? You could see the difference visibly. On the left is the adult, on the right is the kid. You could hear it, but now there has to be some data behind it. How do we do that? And so, if the patient is not conscious and not breathing normally, it's very simple. Start CPR, right? And then once you start CPR, very simple. Don't stop CPR, right? This should be the mantra moving forward at your communication center. So, very simple. We have CARES now throughout the state of Florida. Chief Tommy DiBernardo did an amazing job getting everyone on that. Now it's very simple. You go there and you actually can now add in the times. So after every cardiac arrest, you have your dispatch folks plug in these times. This is all part of the CARES module. And then at the end, once you put that in, at the end of the quarter, you get the result. You know your data. You can now compare your data to Palm Beach, Broward, Northern Florida, Orlando, all that. Easy, right? Please, this is something that we should be doing today. So that was it. This is what I call the R&D link from Dr. Shepke. He uses that term. You can get all my resources for telephone CPR, call, email, text. Now find me on the Twitter. But again, Dr. Pepe, Dr. Shepke, Dr. Van Dillen, thank you guys for putting this together. Thank you for having me. And then I'll stay on here and take any questions that you have. And by the way, just to let you know, yes, Florida is the greatest peninsula in the world, specifically for EMS. It's because of the people who put on this conference. So thank you guys, and happy to take any questions.
No, it's great. Peter, that was terrific. And then I think you're online with us today. And I may ask you a couple questions, but the main thing I want to get across is that we are trying to make sure that we're taking care of every part of the links in the chain of survival. And it turns out there's not 3 or 4 links. There's probably about 100 of them. But this was a key thing. And I think the psychological component of dealing with kids really does make a tremendous difference, and you got to be aware of that. I think you've brought out a really important point where people are hesitant to start, and there's nothing more important than doing it as early as possible with kids, because unlike the guy with VFib who's totally oxygenated and then collapses, these kids are usually gotten to be hypoxemic, and that led to the arrest. So they're way behind the 8 ball by the time we get to them. So thanks for really bringing this to our attention and making sure we refocus on the dispatch office. And Ken, you saw some really terrific things in Palm Beach County, particularly when Peter got involved. But in general, when you started the No-No-Go program that he was talking about, correct?
Absolutely. First, yeah, we all, I think, owe Peter a debt of gratitude for changing what we always thought about kids and actually start treating kids like little adults, because there's the psychological barrier to CPR, I think, that really causes us to scoop and run rather than do what we do with adults, which is continue just compression, which is fantastic. And yes, with the dispatcher CPR, Peter's been fantastic. So is Jim Roach. They've both been pioneers in this area. And we started listening to these tapes. And I'll tell you, for all the medical directors listening, I encourage you to go listen to your cardiac arrest tapes, because it was a true eye opener for me, because it was taking us 5-6 minutes, if ever, to get to the point of advising someone to do compressions. And now, thanks to Peter, thanks to Jim Roach and others, and Charlie Coyle at Palm Beach County, we're now down to below the 2-minute mark. So it's fantastic. It saves a lot of lives. We've seen it in our numbers, and this stuff really does work.
Yeah. Hey, Dr. Van Dillen, do you have any questions for Peter? I'm not sure if he's still on the line or not, but we'll see if he is. So go ahead.
Yeah, I see him. He's there.
I'm here.
Well, I mean, I think that this is just amazing, and I think that just really coming out there and talking about pediatric cardiac arrest, getting in the dispatch. I mean, I really truly feel like, saving lives, and this really starts at the 911 call. And I think every time we go back to the dispatch, we really get to some time and some significant interventions that can be done from the very beginning, especially with cardiac arrest. And so I'm glad that you are bringing us back to where it all starts. I think that's important.
And so, Peter, you have anything to add to this in terms of before you go on to the next speaker?
I just want to thank everybody for what they've done and all the research. It doesn't take a pediatrician to do the research on this stuff. And Paul, you've led the way, both Pauls. But really, the one major point here is that we have to get out of our head that kids are any different. And it took me, I've been doing this for 21 years, and I would have to say that for most of my career, I was completely wrong. And I'm just very grateful to be working with people who are helping kind of move the message that kids need to be treated with the same level of care as we do for adults. So thank you guys very much.
But I think what's kind of cool has been the synergy of the different people bringing perspective. So, for example, you can see the great success that Polk County had. Part of that was the training that the chiefs did in terms of getting people around the verbal judo, me bringing the ventilatory part in, you bring in the system one thinking, and I could go on to all the people that contributed to that kind of success. And then here's another level that you're taking us to. So I think this has been fantastic. So thank you very much, and hopefully you'll be with us later when we have our roundtable, Peter. And again, thank you for your work during the COVID crisis. Really appreciate it. So having said that, our first session that we had was one that I called the 2020 Vision of Cardiopulmonary Resuscitation, and all this has been wrapped around that. We're now going to transition to the next area where Florida has taken a leadership role, and that is in some of the, as I call it, the Save the Neurons section that we're going to go to, or the Save the Neurons session. And so with that, we will continue to show how the state of Florida is the world's most wonderful peninsula, and particularly for the United States. And so with that, we want to start going into the neurological areas. One of the things that I thought was pretty cool was bringing up the issue of how important it is to mind the fainting spell, so to speak. And our next speaker is Marshall Frank, who's going to talk about minding your P's and Q's in a fainting spell, and how to size up your syncope seriously on scene. And so Marshall Frank, if you don't know, he's been the Secretary Treasurer for your organization for the last year or two, and will continue on. And he's the medical director for not only for Sarasota County and the Suncoast Technical College there, but he's also the medical director for the City of Sarasota Police Department. And he's done a terrific job for us there already. And Ken, you know him fairly well. You might want to make another couple comments before I bring him on.
Yeah, sure. I got to tell you, first, Sarasota is a really progressive EMS system that has largely to do with Marshall's leadership, and they're really fantastic with their CQI. They measure pretty much everything. They're really a model for all of us, and Marshall's made some great headway in improving care for the citizens he serves. So he's a great speaker. I'm looking forward to seeing what he's got to say.
Okay, good. So then I'll go ahead without further ado. Let's bring on Marshall Frank and talking about something, as I said before, is minding your P's and Q's in a fainting spell, sizing up syncope seriously on scene.
Greetings. My name is Marshall Frank. I'm an emergency physician and EMS physician in Sarasota. I'm the medical director of the Sarasota County Fire Department and Suncoast Technical College, both in Sarasota. I'm going to be talking today on presenting minding your P's and Q's in a fainting spell, sizing up syncope seriously on scene. I'm going to start with a brief case presentation. So EMS is activated for a 32-year-old man who had a syncopal episode. You arrive on the scene. You find him to be awake, alert, and oriented. He feels well. He really has no complaints. His significant other is on the scene. She says, you know what? He lost consciousness for a brief period of time on the couch. He was maybe unconscious for about 15 seconds, and then he woke up on his own. The patient says, you know what? I don't think you guys really need to be here. You're wasting your time. I've had 3 days of diarrhea, and I think I'm just dehydrated. I think that's why I passed out. You start talking to the patient, and he says, he has a past medical history of opioid dependence in the past, and he also has schizophrenia. His medicines are methadone and ziprasidone, which is Geodon, if you're more familiar with that. Again, the patient says, you know what, yeah, I think you can go, you can leave. I don't really need to have any treatment. I certainly don't need to be transported to the hospital, but you advocate to get an ECG, which he allows you to do, and this is what you get. So take a look at it for a brief period of time. We'll discuss this further in a minute. And what I want to do is talk about and advocate for you to always get an EKG in syncope, and I'm going to go over a few reasons why. So in syncope, if we get an EKG on somebody, and we can always recognize radiodysrhythmias, tachydysrhythmias, STEMI. These are things that we're very good at. And so, for example, if you got an EKG on a patient with syncope, and this is what you saw, the heart rate here is 20, and you won't be surprised that this is likely the cause of the syncope. But unfortunately, it's not as easy as that always. Now, what I want to do is review 4 subtle findings that we can pick up on EKG that really has the potential to make a difference and impact the patient's outcome and really improve patient care. And those 4 things are Wolff-Parkinson-White syndrome, Brugada syndrome, hypertrophic cardiomyopathy, and prolongation of the QTC. So I know I have a brief period of time, but I want to discuss each of those very briefly. I think each of those can have their own hour-long or more case discussions, but this is just a very brief overview. So this is an EKG of Wolff-Parkinson-White syndrome. And what we see in this EKG is that it's a pre-excitation phenomenon, and we get what's called as delta waves in some of the leads, which is caused from a short PR interval. Remember that the PR interval should be 120 to 200 milliseconds, and in Wolff-Parkinson-White, the PR interval is short. And that's because you develop what's called as an accessory pathway. You can see in this diagram. And so in addition to the AV node, the accessory pathway conducts electricity, and you basically have an early depolarization of the myocardium. That's why it's called pre-excitation, and you develop these characteristic delta waves. So why we care about that is these patients can develop Wolff-Parkinson-White syndrome with atrial fibrillation or atrial fibrillation with Wolff-Parkinson-White, and this is a characteristic EKG finding of AFib with WPW. So again, this is something we can talk about on its own, but it's something that you have to be familiar with and be able to recognize. The next is Brugada syndrome. This is characterized as a sodium channel problem in the myocardium, a sodium channelopathy. There's characteristic findings of ST changes in the anterior leads. The problem with Brugada syndrome is that it can cause ventricular fibrillation, which is obviously bad. These people need AICD placement. They need the implantable cardioverter defibrillator placement. Undiagnosed, the mortality is about 10% per year. So it's very important that we find these people, we diagnose them, and we get them in the right clinical management. The next thing is hypertrophic cardiomyopathy. This is typically a young person, maybe with exertional syncope. The characteristic finding on EKG is left ventricular hypertrophy, left atrial enlargement, and you'll see a big Q wave, usually usually greater than 3 millimeters in the inferior, the lateral, or the anterior leads, which we see here. These people are at risk for sudden cardiac death, and sometimes it's thought that syncope in the setting of hypertrophic cardiomyopathy may be a warning sign of sudden cardiac death to come. And the next, and you may recognize this EKG, is prolongation of the QTC. And this the problem with this is that this can lead to torsades, which is a polymorphic VTAC. And you can see that this EKG, the QTC is prolonged. And in this patient, when we go back to the case presentation, this patient was on methadone and geodon, both of which have known to prolong the QTC. And he's also had diarrhea, which we learned later on. He was hypokalemic, the potassium level was low, which also prolongs the QTC. So this patient had prolongation of the QTC. He may have had torsades, which caused a syncope, and then it resolved on its own, and then he woke up. And the American College of Emergency Physicians clinical policy advocates for EKG to obtain an EKG in syncope. In fact, it's the only level A recommendation for diagnostic testing to help risk stratify patients. So I would very much advocate for you to obtain an EKG on every syncope patient, because you can find one of these 4 subtle findings and really have an impact on patient care and improve their outcomes. Thanks for your time.
Okay, thank you very much. That was terrific and a good reminder. I mean, for some people this may seem real basic, but it's just totally forgotten, and it's really straightforward stuff. And it's in my mind, but I think it's an important thing. Just like in the cases of overdoses, we think about, should we ventilate for them? Should we give them Narcan? But the other part is, should you check to see if the EKG has things like this going on? So this is just an important part for all of us to remember, that it's so easy to get an EKG now and to look for those things and know those intervals and so on that we were pointing out just now. So I think that's fantastic, and thanks for that talk. Any reaction to that, Ken, that you want to point out?
Yeah, I think it's a good reminder that we get one shot to get things right, so we have to go in there being the pessimist. Let's not assume that the syncope is due to some benign thing like dehydration, when there could be an underlying life-threatening cause. So you have to approach all of these pre-hospital cases as, what's the bad thing we're missing here, and not jump onto the good positive cause that first presents itself.
Yeah. So, before I get on to the next part here, I just want to point out, if you go back and think about what's happened, we heard about head-up CPR. The first clinical presentation about head-up CPR came out of Florida, and it was last year published in the big high-impact journal Critical Care that went worldwide, and was actually the most popular paper, and it was the editor's choice article in this high-impact journal. It came out of Florida. When we heard about the cardiac arrest information, about pediatrics, it's actually changed practice. It was like in journal clubs around the world, the stuff that Paul Banerjee put out. If you go ahead and look at the issues that, for example, as we just heard about with from these other areas, it's that you're just taking some initiatives and really pushing them forward. In this next case, I just want to bring up is that our next speaker is going to be Dr. Shepke, who is our state medical director. And it's, again, another neurological thing, and it's just another forward thinking. I just have to say, this presentation you're about to hear is not only just really a compelling data they found in both Palm Beach County and also Broward County, but it also was with neuroscientists, leading neuroscientists, interventionalists, critical care specialists in the audience, sat there, and he got the Star Research Achievement Award from the Society for Critical Care Medicine for this. So with that, I want to bring on Dr. Ken Shepke. But Chrissy, you're the president for our organization of the Florida Association of EMS Medical Directors, and it might be really good for you to comment about him. I could go on forever, and it would just basically, I think, trivialize what he's accomplished for us. But if you don't mind, as our leader, let us know what you think.
Well, I think that one of the things that this presentation and many of the things that Dr. Shepke has done for us is that he knows no boundaries, because he thinks outside the box, and he pushes forward. He makes connections. He utilizes the best resources possible. The neuroscientists. He goes right to the source, and so we're very lucky to be here with him. In the, let's say, in the ambulance with him in the driver's seat, because he's leading us, I feel, and upward and mobile in the EMS across the state of Florida. I think we're really lucky. He's doing a great job, and this is just one example of one of the things that he's doing amongst many things. So thank you, Dr. Shepke, and we're here to help, and we're going to try to expand across the state these protocols as well.
Hey, and I got to say is that if you don't know, one of the cool parts for me is I learn a lot from Ken, because he's actually got incredible knowledge of physiology, especially basic physiology, and that's going to be important and integral to the talk we're about to hear, and he'll explain to you a little bit once we get towards the end of the talk. And so with that, and without further ado, let's bring on Ken Shepke to talk about using ketamine for benzodiazepine refractory status epilepticus. So I call it terminating the interminable seizure, pre-hospital ketamine for status epilepticus. Dr. Ken Shepke.
Oh, thank you both for the kind words. This is a great topic. I think it's one I find really interesting, and hopefully everyone else will find it interesting too. So we have this problem here. We are not a pharmacy, right? We've got limited medications in the field, and if you get somebody who's got a seizure and you give them your usual benzodiazepine and they keep seizing, what do? And this is a big problem. And this is clearly what we call a seconds to minutes emergency, because lifetime risk of status epilepticus, 15% of seizure patients. So if you're a seizure patient, you got a 15% chance over the course of your lifetime that you'll have this. And if you do get this, the death rate's literally 1 out of 3 in adults. So it's very high death rate in adults. Some status cases, doesn't matter how much Versed or Valium or Ativan, when you pick one of those, it's just not going to stop. So what do you do? What can we do now? I mean, the answer always has been for us, diesel, step on the gas, get to the hospital, let them worry about it. But there are people, especially, and even in Palm Beach County, we've got rural areas where we've got prolonged transport times, and the longer you allow somebody being status epilepticus, the more neurons are going to die. And since this section is all about save the neuron, I want to talk about how do we save the neurons. So what do we do if the benzos fail? And that actually happened to me. I had one of my EMS captains give me a call, and they said, "Doc, we're far out from the hospital. We're coming from the Western communities. This patient's still seizing. What do we do?" And that actually was the impetus to go down this road I'm going to talk about here. And first, I do have a disclosure, and many of you have seen this slide before. I truly do think that ketamine is for everything. In fact, my next study is going to be ketamine for curing COVID. I'm not sure how well it's going to work out, but I am going to work on that because it does seem to do just about everything. It's a sedative. It gives you pain relief. We use it for that. Amnesia. It's a bronchodilator, which is why it's the drug of choice for sedating patients who have to intubate with asthma. And it's anti-seizure. And while it's not considered a first-line drug for seizure, when your first-line drug fails and if you're already carrying this, well, all right, maybe it's an option. So this was our hypothesis, that if EMS administered parenteral ketamine, that it will resolve seizures in midazolam refractory status epilepticus. That was our hypothesis going into the study. I combined with Coral Springs Parkland Fire Rescue and Peter Antevi, and we started gathering data, and we put out a protocol there. And from January 2017 to 2019, we gathered cases, both kids and adults, because we treat kids the same as adults. And the protocol was after they've gotten the full dose of benzos, which we defined as 10 milligrams of midazolam or the equivalent dose in kids, then we were going to go give them ketamine. We did require some of our better clinicians, our more experienced clinicians, to be overseeing this protocol because it was so new. So that's our EMS captains. That's often how we roll out new stuff for EMS, is we let the EMS captains get involved. And our dose that we picked was 100 milligrams IV or IO, or 1 milligram per kilo in kids. Or if you didn't have vascular access, you could do 3 milligrams per kilo intramuscularly. So we had 3 different routes. And these are our patient demographics. We got 22 total cases. They ranged in age from as low as 5 to as high as 86. The mean age was 37. What was interesting here is 3/4 were female, which is unusual in status epilepticus. It's more often in male when you look at the literature. And we gave 13 times IV, 3 times IO, and 6 times IM. So what were our results? So of the cases that were seizing despite full dose of benzos, just about 96% of them resolve after a dose of ketamine, which we thought was remarkable. And if you look at the p-value on this, it's super, even though it's only 22 cases, this is super highly statistically significant. And even in the one case, there was only one case that it did not completely resolve. Even that case, the seizures slowed down. They kept having seizures intermittently, but instead of being constant and severe, it slowed down and became intermittent. So I suspect in that case, even we got improvement. I suspect if we gave another dose of ketamine, we may have been able sedatives, and particularly when you start combining sedatives, like you're giving benzos and now you're giving ketamine on top of it, certainly we worry about untoward effects, especially hypoxia. So we found 5 out of the 22 cases actually did have an O2 sat below 90. That's what we defined as hypoxia. But when we looked at it, 2 out of the 5, man, they were hypoxic before you give ketamine. And that's because not only does midazolam, reduce your respiratory drive somewhat, but the seizure itself, status epilepticus, makes your ventilatory mechanics. They're all messed up. So you're not really ventilating very well just from the status. We did find, fortunately, that pretty much all of them got better. Well, I mean, they all did get better, but 4 out of the 5, just give them an oxygen. That's it. That fixed it. And in one case, we did do BVM. There was one case that was intubated after arrival to the emergency department, but that was after the patient already had normalization of the oxygenation, and it was felt to be done simply for airway protection. So our conclusion was ketamine, highly effective at terminating benzodiazepine refractory status epilepticus in the pre-hospital arena. And this was a great thing, and it's something that we've now embraced and we continue to do. Brief hypoxia in a small number, so we do have to be ready to go with our bag valve mask or supplemental oxygen. And hypoxia, fortunately, was really reversed in all cases. So that's what I wanted to talk about. Thanks, and I appreciate the opportunity to bring that to the rest of you across Florida here.
That's terrific, Ken. Hey, Ken, the other thing I was going to ask you about is that you are brilliant. You have biochemical background. I mean, you really understand stuff. And one of the things I wanted to ask you about is that one I understand from the neuroscientists when I saw your presentation at the Society of Critical Care Medicine was the issue about how ketamine works versus, say, benzos, that different receptor sites are upregulated or downregulated. Can you mention that for me, if you don't mind?
Paul, it's almost as if I anticipated you want to ask me that question because I put a slide just for your question.
Oh, good.
so it turns out that just about all anti-seizure meds work on the GABA receptors. So the GABA receptors is basically the off switch for the brain. So when you stimulate the GABA receptor, you put the brain to sleep. So if you already have too much activity, you give it benzodiazepine or Dilantin or any of the other seizure meds that we typically would follow, and that's going to hit the GABA receptors. But the problem with status epilepticus is the longer you're seizing, the more downregulated or the fewer GABA receptors exist. So these switches that you're trying to hit with your anti-seizure meds, they disappear over time. But at the same time that the GABA receptors are disappearing, the NMDA receptors are increasing. They are getting upregulated. So the longer you have a seizure, the higher the number of NMDA receptors. And the NMDA receptor is basically the on switch for the brain. So if you stimulate the NMDA receptor, that gives you a hyperactive brain. But if you block the NMDA receptor, well, that's the same thing as an off switch. And guess where ketamine works? Ketamine is an NMDA blocker. So it turns out there's 2 ways to stop the seizure. 1 is stimulate the off switch, or 2 is to block the on switch. So it makes perfect sense that when benzodiazepines fail, other seizure medicines that work at the GABA will also fail. And that's really what we see in the literature. But if you switch classes to an NMDA blocker like ketamine, now you're going to see success. And I think that's some of the reason why we see such high success in our study. Well, with that, thank you again.
Okay, you're welcome. And that was really a cool, actually, explanation. So thank you very much. So I was going to say that this is, again, you can see why this got into work. I mean, you only had like 22 patients in the original cohort that you presented, and yet it's so significant. I mean, extraordinarily significant because you had so many people that converted. I mean, in a sense, you had 100% improvements on people, and in 95% you completely terminated it. So I think this is pretty cool. That I'm going to make sure we get that across worldwide, and we'll try to publish this here pretty soon, I hope. So, Chris, anything else you want to add to that before we go on to our next speaker?
I mean, ketamine's a wonderful drug. I mean, do you think, Dr. Shepke, do you think that you can look at ketamine treating COVID for us?
Well, that's my next research project. I don't want to give too much away, but that's coming up.
That's great. So as you've heard, the state of Florida is coming out with some really advances and getting a lot of awards that are out there for us and so on. But what I do want to say that what I'd like to do is move on to something else that's been a really great leadership role. When we've had our gathering of Eagles on the national level 5-6 years ago, we were hearing about how people were setting up comprehensive stroke centers. We heard how it was making a difference in outcomes, and we were all jealous, and we wanted to get that happening. Well, it didn't just happen by accident. A lot of great work was being done in this area, not only in setting up a statewide registry, but also in making sure that legislation went through. And one of the people that have been leading this for a long time has been Charlie Sand. Charlie Sand, as you know, has been not only a prudent leader in our world, and so on, but he has been really a strong advocate, serving as a president of the American Heart Association Florida, Puerto Rico Board of Directors, and been a member of the American Stroke Association National Advisory Committee. I could go on and on. He's been our Florida College of Emergency Physicians Member of the Year, and he's won all sorts of awards. And you can see why, because of some of the things that he has been accomplishing in the last few years. So, Ken, you might want to say something because you've worked with him for so long yourself.
I got to say, I first began to know Charlie way back when he would give the ACLS updates. So yeah, Charlie's been involved and been a leader in Florida and EMS for a long time, probably longer than he wants me to admit for him. But I'll tell you, Florida really owes him a debt of gratitude for all his work on stroke. He's been at the tip of the spear all along. He got the first he was really instrumental in getting Florida to be the first state in the country to get stroke legislation in terms of EMS destination, get primary stroke centers up and running. He developed the first EMS stroke triage and assessment tool. He did the updates to the triage and assessment tool as the updates came out, as the science changed to go into vascular therapy. So he's really quite the mover and shaker in Florida, and really we all owe him a great debt of gratitude for his leadership over the years.
Okay. Well, with that, let's go ahead. Without further ado, let's turn it over to Charlie Sand, and we're going to hear a little bit about what's happening in the leadership roles that Florida's taken in the management of stroke.
Good morning. It's a pleasure to be here. I appreciate being invited to do this lecture on what we're doing in Florida with stroke. Here's some of the things I've done and been involved with the registry and American Heart Association and EMS. So I have to give a disclosure of my conflict. Clearly, Florida's the best in the world of stroke. We provide the best stroke care. So we can argue about it later. That's my conflict. Multiple people have contributed to this, and you'll recognize many of these people, past and present. But just want to point out Dr. Shepke wishes he was still working the emergency department, and you can see how busy an ER. I work at St. Joe's, so one of the top 5 volumes in the state, and you can see me working hard. More and more people, rest in peace, the Oriole, Dr. Silvestri. And the biggest thank you to Dr. Pepe for bringing the Eagles to Clincon and contribution to stroke care worldwide, and now we're lucky to have them in Florida. So we're going to answer 3 questions today. What has Florida done in stroke? What's the Florida Stroke Registry? What's it accomplished? And where is stroke care and the Florida Registry going moving forward? So first, what's Florida done? Florida's done a lot. We'll cover a few things. One, we've given multiple lectures since TPA came out. 2001, our very active and great leadership in Florida Association of EMS Medical Directors, wrote a position statement saying EMS should be transporting our stroke patients to the most appropriate hospital for TPA. And finally, in 2002, and 2003, we continued with collaborative efforts to improve stroke system of care. We formed pockets of regionalized collaboration. The first was in West Central Florida, where we compare notes and boost everybody up to the next level. I always show the most updated list from the state site of where the hospitals are located, primary, comprehensive, attested, acute stroke ready hospitals. Dr. Antevi, Shepke, and many others did the same great effort at Southeast Florida Stroke Coalition. So 2003, we've gone some places, but we were still facing many geopolitical barriers. We decided the only way we're going to get this done right to optimize stroke care in Florida was legislation. So in 2004, after a year of meetings and collaboration and multiple legislative testifying to the different departments, we passed a Stroke Act, first in the nation to do so. And you can see on the left me, much younger, much more hair, and no gray hair. So wish I could go back to those days. Sort of depressing slide. Florida Stroke Act ensured that EMS knows which hospital to take them. We had a EMS stroke alert form everybody had to have, and we've updated that through the years through the EMS Medical Directors Group as intervention and things like that have come to fruition. We still carry one of the most primary and comprehensive stroke centers in the nation, and I think we continue to collaborate and improve systems of care, and you'll see some evidence of that in a little bit. We modified the Stroke Act 2017. Acute stroke ready hospitals entered into legislation, and this is the big one, mandating all Florida stroke centers participate in a Florida stroke registry. 2019, we got rid of CEO attestation and required certification by hospitals by nationally recognized guidelines. We can go over that in the panel if you want. We added LVO and thrombectomy capable centers to keep up with the cutting edge nomenclature. So what is Stroke Registry? Florida Stroke Registry, what does it accomplish in Florida? Great people, world renowned on this team. I want to thank Carolina particularly for all the help she has done, helped me with this lecture. So this the Florida Stroke Registry began as an NIH-funded program. Now it's DOH, state of Florida, DOH-funded. And you can see our mission. Our mission is to track and measure hospital stroke performance metrics, develop evidence-based interventions and initiatives, and ensure health quality for all Floridians. This is a busy slide, but really a powerful slide. We, again, focus on most vulnerable, the elderly, racially diverse. Focus on this and look at it when there's more time. From 2010 to 2019, how's Florida done during the registry years? IV lytics has improved from 7% to 14%. It's doubled in 9 years. IV lytics from 3.5 to 4.5 hours, gone from 57% to 92%. These are the most incredible numbers to me, at least. Door to needle, 60 minutes. Door to needle, 45 minutes, 19% to 91%. And from 6% to 69%. Absolutely astounding. Defect-free care, practicing evidence-based medicine from 2/3 of the hospitals are doing it to now 93%. We continue to recruit Florida stroke centers, and we continue to educate with cutting-edge things such as COVID-19. Here's where we are. We still haven't got to all hospitals in Florida, 161. That's our goal. You can see the distribution. And just focus on the bottom. We give quarterly reports, hospital-specific, county-specific, and collaboration between hospitals and EMS. These are the dashboards that are full of incredibly valuable information, both EMS and hospitals. We have 16 reperfusion therapy measures and outcomes, IV lytics, and endovascular measures. And just focus on the right part of this slide. We'll go over some dashboards in a minute. And you can see quarterly snapshots of individual hospitals and all measures, quarterly snapshots of all counties group by lytics and endovascular trends of hospitals benchmark against multiple surrounding counties. And this is an example of the dashboard to show you how they work. It goes by ischemic volumes, whether you're low volume, defined as that, medium, 80 to 180 ischemic stroke patients, and high volume, greater than 181. You can see here's all the hospitals in this particular county, for example. This hospital had 60 ischemic stroke patients, 153. And how many got TPA? This was 29%, doing phenomenally. Okay, they're doing phenomenal. They are the benchmark. They should market themselves. All the other data is de-identified, but they can probably guess based on volumes. These hospitals really need to up their game. And hopefully with collaborative efforts, they will. And EMS ultimately has the prerogative to decide where to transport patients based on these outcomes data. Here's medium door to needle. Here's endovascular data, door to groin, where you want to be as fast as possible. And you can see we want everybody to be here. Maybe EMS transports only to those who are doing the best job eventually. But hopefully every hospital will come down to there. And here's percent overall endovascular treatment. These guys are doing great. These hospitals, 12%. These need to up their game a little bit, but it's okay. There's room for improvement. That's the purpose. Desi slide. Here's all Florida Stroke Registry, gets all that data, plugs it in, shares it, and hopeful collaboration between EMS and hospitals. And just a recent shot of the beach. And I have no idea why the volumes come up. I mean, they're keeping distancing, they're wearing masks, but who knows why everything's going up with COVID. Multiple registrations, including here, Clincon, multiple publications. You can see some familiar names. Educational efforts. We have annual meetings, collaborate EMS hospitals, legislators, and educational efforts. Here's a COVID survey. And for time purpose, you go on your own, but I'm just going to hit some highlights. More telehealth so we don't contaminate people. Only one member. We intubate in the ED to save time. We've cut up 35 minutes in our particular hospital. And I think you're aware of the numbers. And here's, I think everyone knows, just a similar thing. Use telemedicine, use smartphones, use tablets, intubate in the ED, safe for negative isolation, air isolation. Get all your studies at one time, including CT angio, CT perfusion. Decrease exposure, CT scanner, we've already gone over that, and just similar at all of our pockets in our state. Outpatient follow-up through teleneurology. So where are we going? Here's the slide you remember. Here's our dashboards of continued utilization dashboards and enhanced collaboration. And notice the pockets at the beginning who've been doing this for a while. Collaboration, they're very strong. Here's our opportunity for target counties. We want all of you who are involved in these counties, please let us know if you're interested in helping us out. We want more collaborative efforts for these dashboards. And the final slide, future, we want to access data, obtain 100% hospitals, increase statewide participation in these regional collaboration dashboards, enhance membership, increase the impact in all phases from pre-hospital to ED to the hospital to post-hospital. And there's the email you can get a hold of. We've gone over the 3 questions. Please utilize what you want. Go out there, save some brains, and thank you. I appreciate it.
All right. Well, thank you, Charlie. That is a lot of information, and the point, though, is that we just want to let you know what is going on, how it's going on, and where we're going with it. And Charlie can be there for you anytime. Contact him to give you more information and get you in the right direction as needed. So one thing, I don't know, Peter and Tevi, if you're still on, a lot of this work also took place in collaboration with Dr. Sacco down at the University of Miami. Can you tell us a little bit about that and how you see it's changed things in the last few years?
Yeah, absolutely. This was very serendipitous that they had this huge kind of process going on with an NIH-funded grant. We ended up having a conversation, and then they kind of quickly turned it into an EMS data collection tool that is now being funded by the state. So people like Charlie, obviously, Charlie, great talk, and with Ken's leadership at the state level and with Paul, being in on all these conversations, helping with the research. It's just been something that we've been very fortunate to have Dr. Sacco, Dr. Mehta. The entire community has been phenomenal here for stroke, and just been grateful for that.
And what's really cool, you guys are really changing the outcome. By the same time, we've also seen where there are, as everybody says, politically correct opportunity for improvement. But one of the things I thought was really interesting that came out of it, we actually looked at the delays in people. One of the studies that came out of that we all participated in was the delays in getting to the stroke center. And we actually looked at the different time things that may delay, like the time to call 911 or the time on the phone at the dispatch center or the time in responding to you, or now we're on scene more with, getting EKG, glucose, the stroke scales, etc. And then we're bypassing other places to go to a comprehensive stroke center. So you want to know where were the delays. It turned out on the average, it was almost 6 hours on a delay, even when people ended up calling 911 to go in. It wasn't like they went through a clinic or something, they just called in. In that setting, it turns out that it was a lot of time. And what we found out, interestingly enough, is that we thought maybe the EMS thing or the bypassing hospitals would take a lot of the time. That was only a half an hour of it. It was 5 hours of it was people waiting to get on the call. So what I'm getting at, we could have, just like with bystander CPR, we get there and we could do all these great things, but if no one was doing bystander CPR for us, it's a problem. So in this area, we need to do our homework and making sure people get recognition of the stroke early on, and then so make that part of your plan. It's not just setting up comprehensive stroke centers, it's also educating the public, and we have to take the same kind of I think leadership role we've done in those arenas too. But I'm saying I think the registry for helping us identify these kinds of things. Ken, you've worked with it now, especially since you've set up a lot of the comprehensive stroke centers have been very successful. Anything you could add to that?
Well, I got to tell you first, thanks to Peter and Charlie and several other folks that we just mentioned, Dr. Sacco and all. We've heard this old adage, if you don't measure it, you can't improve it. And having this data come in, it allows us to discover the best practices and go to the hospitals that have the best practices and say, hey, listen, why don't you share what you're doing with others, because you may be the one with the stroke and you might not be brought to your hospital. So let's take competition out of this and just make this improvement for everybody. And with that attitude, we've really seen an improvement in stroke care all across South Florida, and now it's spreading across the rest of Florida as well.
Yeah, and so I just want to, again, because of the legislative actions, it's really now going to have teeth and take route that people in the hospitals and the facilities have to give us the information and not self-declare that they're a stroke center. They got to prove it.
That's a big deal.
So we really thank Dr. Sacco, Charlie, and the others who are making this all possible with the numbers. Be the source, become the force, as we've said, right? So it's good. So hey, so a little bit about the next speaker, Dr. Jameson, and Dr. Jameson is the medical director for Pinellas County, and he's got a whole crew of people, like almost 2,000 EMTs and paramedics across 20 agencies. So he's got quite a job. And, as you know him, he's worked also in various arenas and been taking a great leadership role for us. And Ken, can you reflect upon that a little bit? And Angus, I think he's one of our board members with the Florida Association as well. So
he is. He's one of the board members, and deservedly so. Angus has been another great leader in EMS for a long time. Another person who's really been focusing on data and improving systems. He's got a master's in public health. He's board certified in both emergency medicine and EMS. He's another one of those overachievers that we have in Florida, but we're so fortunate to have him heading one of the larger EMS systems. He's really an expert in multiple different areas, including stroke, cardiac arrest, really systems improvements. And he's always got something good to say and share ideas with at our state meeting. So I'm real happy to have him on the panel today, and I'm looking forward to hearing what he's got to say.
And Dr. Van Dillen is the president of the Florida Association. Any other comments you have from him? He's one of your board members, and so you get to work with him.
Yes, he is always present, always available, always giving good insights from his point of view. And so I'm very excited that he's a part of our leadership at the Florida Association of EMS Medical Directors, and not surprised when he comes in with these exciting new protocols and changes.
So it's interesting too. One of the things that Ken said in this little sidebar here, digression, is that I see that there's a lot of people who are actually board certified here in the state in the discipline, the official discipline of emergency medical services. and in the House of Medicine. So it's very cool to see this transpiring across the state and really lifting up our standards here. So with that, without further ado, I want to bring on Angus Jameson. And what I've asked him to talk about today is, as I call it, reassessing assessments and delineating, for example, strokes from intracranial bleeds and so on. What are some of the tips that'll help us make sure we know if we should be going to a trauma center versus, say, a comprehensive stroke center? And so that brings up at a very interesting point, because you got to try to figure out which is which, and that may be a dilemma for us. And so let's add another tool. So thanks to Angus, we have one. So with that, can I bring on Angus's video?
Hey everybody, my name is Angus Jameson. I'm the Pinellas County EMS Medical Director, and I want to talk to you today quickly about delineating strokes from intracranial hemorrhage and what you need to do about those. So here we go. There's my stuff and where we are, and with that we'll go ahead and get started. So a couple of questions I hear a lot these days, particularly with all the amazing great advances that have happened in the care of stroke patients here in Florida. I hear, should I declare a stroke alert on a head bleed? Can I tell the difference between a stroke and a head bleed? And should I take a head bleed to a comprehensive stroke center? All these are really good questions. All of them have a slightly complicated answer, so let's go ahead and get to it. So quick review, we use a couple different ways to approach patients. We can use active deductive reasoning, which is following a very structured differential diagnosis-like pathway. We can also use pattern recognition. You have a cartoon character, probably picture in your head, if you've been doing this for a little while, of this is what a guy having a heart attack looks like. So, you know, maybe he's older, maybe he's got diabetes, maybe he's obese, maybe he's telling you there's an elephant sitting on his chest and that his pain goes to his left arm and maybe his jaw. So either way, that's your sort of archetypical picture of what somebody having a heart attack looks like. Similarly, you probably have a picture in your head of what a sick baby looks like. You can tell pretty quick that's a sick baby just by taking one look at him. You can contrast that with the image in your head of what a well baby looks like. Remember, expert clinicians use a combination of both of these things, but you got to have this pattern recognition stuff in here to be fast and to be expert. So let's get into those patterns. This is a pattern of somebody having a stroke. So this is a guy with a droopy face and telling you his arm doesn't work, telling you a specific part of him doesn't work. Now that's great, but is that the same pattern as somebody having epidural, subdural, hemorrhagic stroke? What's the difference between a hemorrhagic stroke and an ischemic stroke? How do you contrast that from a subarachnoid? Do all of these folks need stroke alerts, and which ones need comprehensive stroke centers? All good questions. Doesn't quite all fit right into this one pattern. So let's see what they are. A classic ischemic stroke pattern is one part of me, and here's an example of the precentral gyrus that does motor function, which is then controlled by the middle cerebral artery right here, which then you can see with the chart gives you a hemiparesis, okay? So it's one part of my brain is ticked off because there's no blood flow to that part of the brain, and therefore that part of me doesn't work. That's a focal neurologic finding. Just like think like a focal seizure, one part of me doesn't work, right? This is exactly the same as localizing a heart attack based upon which vessel is involved. So if you see 2, 3 in AVF, you know that's an inferior MI. That's equivalent to saying, hey, it's right here in the brain. And then you go to your little chart and you say, hey, it's this vessel. That's just like going to here. And you can say, hey, I can localize that heart attack to whichever vessel is involved based upon what the EKG is showing me as to which part of the heart is ticked off. The exact same way which part of the brain is ticked off, you can find out which artery it is and what to do about that. Okay, so that's a focal neurologic finding. That's the classic stroke pattern. Contrast that with head bleed patterns. Here are the 3 patterns that I want you to put into your brain, okay? Now, they're a little goofy on purpose because they're supposed to be kind of funny and stick in your memory. So here they are. The first one is the Sharon Stone, okay? That is the subarachnoid hemorrhage. Now, Sharon Stone, for those of you who don't know, is an actress back in the early 2000s. She had this movie that kind of set her up as sort of like a sex symbol, and the reason that's important is because people who have subarachnoids often get them after periods of intense physical activity, such as sex or working out at the gym. This is an aneurysm that's blown. It goes fast, and a small one is the sudden onset thunderclap, worst headache of your life that you've heard about. Classically, a big one, you're going to be down and out, like unconscious, basically dead before you hit the floor kind of stuff. It is, again, arterial and fast, and it happens after periods of good exertion. Okay, so, whether that is somebody having sex or whether that is somebody lifting weights at the gym, whichever it is, that's generally the story. So this is the cartoon character of the Sharon Stone or the weightlifter that I want you to put in your head for a subarachnoid. Sudden onset, worst headache of my life, or down and out. And again, by the way, for those of you who thought going out in a blaze of glory mean having an MI, no, MIs hurt unless you go right into VFib. This is going out in a blaze of glory. My head, and then you're dead before you hit the floor. Okay, that's the first one. The second one is the subdural. It's the goofy grandma, otherwise sometimes known as the alcoholic. These two patient populations have three things in common. They have thin blood. Grandma's on anticoagulants, and chronic alcoholics can't clot their blood as well. They both have shrunken brains. Grandma from cerebral atrophy from being old, the alcoholic from cerebral atrophy from chronic alcohol use, and then they both fall down and go boom a lot, right? So what happens is the veins that drain blood from the head, called bridging veins, they get stretched because of the shrunken head, right? And then when you fall down and go boom, they get a little tear in them, and because you have thin blood, the blood comes out. But these are venous. Again, they're veins, so it's venous and slow, and they may be chronic, subacute, acute, or even mixed. And these can look like anything. I've seen grandma just stopped eating. I've seen grandma all of a sudden became incontinent. I even had one lady bring in her husband to me one time. She said, "Doc, I don't know what's wrong with him. He's just being goofy." I said, "What did you mean?" She said, "Every time he walks down the hallway, he just kind of falls off to the left side and bumps in the wall." I said, "Wow, that is goofy." And she really blew my mind. She goes, "Yeah, he does it when he's driving too, right across the double line." I said, "Oh, geez, welcome to Florida. Scary out there." All right, so that's definitely goofy. Again, this is venous. It's slow. It can be over a long period of time. And the third one is the epidural. This is the ski into the tree, sometimes known as the Natasha Richardson or the Sonny Bono. This is traumatic. Oftentimes it impacts the side of the head, and there's a particular artery there called the middle meningeal artery that's most often involved. That artery runs in a groove on the inside of the brain, and my medics know from the autopsies we do during orientation that I like to show them that groove on the inside of the skull and talk about this in that setting. And I also show them that there's this membrane that's tightly adherent over there, right? And you actually have to use pliers to pull it off. And I show them that because this is the one with the classic textbook period of lucency. And the reason you get that period of lucency is because that membrane there, the periosteum, is actually holding and tamponading off that bleeding. But eventually the arterial pressure overcomes that, and then the brain gets squished by the expanding bleed. So this is the classic period of lucency. This is I skied into the tree, I smacked my head. A lot of times have a quick LOC. Then I went to the ski patrol clinic. They said, "You're okay." They said, "Go home, sleep it off." And 6 hours later, I woke up dead. These are general neurologic findings. That's super important. The difference between a focal seizure of just one part of me, or a generalized seizure where I am unconscious. Super important concept. The difference between a focal or localizable general or a neurologic symptom and a generalizable neurologic symptom. Okay, so those are the three cartoon characters that I want you to add to your repertoire today. And then here's the difference. The stroke or brain attack versus the head bleed. The brain attack is usually a thromboembolic blockage of the vessel. You have those focal neurologic findings. Occasionally you're going to have dizziness or ataxia for posteriors. Those are really tough to diagnose, particularly in the field. And this is your cartoon character for that guy, right? Loss of consciousness and seizure are pretty rare for presentations for these. Again, you should be looking for a focal, localizable neurologic symptoms. And they need this guy. This is our head neurologist over at my hospital, and he comes around with the stroke team and a bottle of TPA to fix these guys, right? Or sometimes takes them to the lab for endovascular. Contrast that with the head bleeds. That's this guy, right? He's blowing his aneurysm. Could also be that goofy grandma. Could also be that ski into the tree. And that is a rupture, a stretching or tearing or laceration of a vessel. And these are going to be general neurologic findings, right? You're going to be unconscious. You're going to be goofy. You're going to have all sorts of other bad stuff going on. And loss of consciousness and seizure are common. Again, progressing right even to posturing and death, right? Treatment is by a neurosurgeon. There's our head neurosurgeon at my hospital with his drill getting ready to open your skull up. So this is the big contrast and compare slide. This is probably the money of the whole thing, right? So brain attacks are going to be focal, head bleeds are going to be generalized for the most part, different pathophysiology, different initial management, different presentation, right? They look different, and different treatment. So there it is. And you may ask yourself, back to our initial questions, how can I tell the difference between a stroke and a head bleed? Well, here you go. Use a combination of pattern recognition along with deductive reasoning to be expert and figure this out. Note that in real life, not all patients look just like the textbook version, and I would say if they do look exactly like the textbook, be a little bit suspicious. Don't forget that donut of discovery is crucial to guide early categorization and treatment of both of these. So, that's the first step for both of these. And then the question, should I declare a stroke alert or go to a comprehensive for a head bleed? Well, a stroke alert gets you the stroke team focused on getting rapid TPR endovascular intervention. It's not wrong to call a stroke alert because it will mobilize resources and get you that quick CT, which you need for both, but it is not going to guarantee you a neurosurgeon or anybody that's going to definitively manage the head bleed. So just bear that in mind. All right, quick bonus slide. Here it is. Signs and symptoms of increased intracranial pressure. First, as your higher cognitive functions go away, you become disoriented. Then, as we show up and we start asking you questions and doing all sorts of stuff that you can't understand because you're disoriented, you start to get a little bit upset with us, right? Then we strap you down. Maybe we poke you with an IV, do all sorts of mean things to you, and your more basic fight or flight kind of stuff kicks in and you become combative with us. And finally, as your brain really gets squished or runs out of glucose or whatever else it is, you become comatose. So that is the progression of symptoms of increasing intracranial pressure, or really lots of other things that cause progressive neurologic dysfunction. End of the day, your patient becomes a dickhead. Again, that's DICC. So in med school, they said if you ever have a patient you just can't stand from the moment you meet them, maybe they're manipulative, maybe they're demanding, maybe they just generally feel like your head's going to explode, they said stop. They said take a deep breath. They said write down borderline personality disorder in the chart. So my challenge to you is when faced with a patient who is just being a total dickhead for no apparent reason, again, DICC head, instead of getting frustrated, angry, stop, take a deep breath, and consider, could they be having a generalized neurologic issue? All right, that's it, everybody. Thanks so much. Hope that was helpful, and stay safe out there.
Okay, well, thanks, Angus. And Angus, I think you're on with us right now live. And so, again, what I want to reinforce is why this is important to know and to differentiate, and it has to do with destination policies, correct?
Yeah, that's the big question is, should I take these folks to a comprehensive stroke center just because I think they're having a bleed? And the answer, at least in our system, and I think in a lot of places, is that a comprehensive stroke center does not necessarily have a neurologist. You can be pretty sure that a trauma center is going to have a neurosurgeon, but a comprehensive stroke center doesn't necessarily have a neurosurgeon attached to it. So that's always a big discussion with my folks about that. And I encourage them, if they really do think it's a head bleed, that a trauma center is probably their best bet in terms of making sure they have rapid access to a neurosurgeon.
Okay, yeah, and that's the main point. Hey, Chrissy or Ken, do you have any particular questions to ask of Angus before we move on? Because we're a little bit behind.
Angus is always an outstanding speaker. I really appreciate that talk. I learned a ton from him all the time. Thank you, Angus, for coming on board.
Yes, I agree. Great talk.
Okay, good. Well, that takes care of that one. Thank you for being succinct. We're going to, obviously, there were some technical glitches here, and we got way behind, almost a half an hour. So we had kind of scheduled a break, but I think, a good time to take a break probably is when I'm talking. So I think it'll be okay. And I think we should move this along so we can get finished on time. I want to make sure that all the speakers that took all the time to do this get to be on, and we get to comment on on all these lectures. But I still want to get everybody out on time, and I want to leave some discussion for our our interactive session at the end that we're going to have. So let's move into the next didactic session, which I call Making Practice Perfect. And the first thing we want to get into is Dr. Jim Roach. Jim has been just an incredible breath of fresh air in South Florida. He came in a few years ago, started running the Broward Sheriff's Office Fire Department medical team. He's the chief medical officer there. He's also the head of the emergency department medical director for the Cleveland Clinic down there in Western Florida. And he's been famous for quality assurance programs, but now he's like getting into it in terms of actually taking leadership roles in a lot of areas and just leaving us behind. There's only a couple places in the country that have started the programs of bringing whole blood to the field. And the question is, well, why are we doing that? And he's going to explain why and the rationale, and it's not that easy to get done. And what are some of the things to get it done? There's some lessons to be learned from both Broward County and San Antonio in particular that he's going to address today. But before I do that, Ken, you're the person that really brought him to the forefront in terms of finding him and recommending that he become the medical director in Broward Sheriff's Office. Can you tell us a little reasons why that you did that?
Yeah, well, first, like I said, I'm a little frustrated by Dr. Roach, to be honest with you. You know, I bring the guy on, and I think, hey, this is an up and coming EMS guy, and I'll show him the ropes. And every time I show him the ropes, he shows me up, and he does it better than me. Yeah, so he's better than I am at CQI. He scooped me on the whole blood thing, which we're about to hear about, because I said, you know, maybe we should bring blood to the field. And sure enough, he does it way faster than I could possibly do it. So, you know, I'm not going to tell him any more ideas, because everything I do, he just, you know, he takes what I would do with mediocrity, and he does it at an expert level. So he's a real star, right? Rising star in EMS. Done a fantastic job with Broward, with the dispatch system at Broward, which we then promptly copied what he did for Palm Beach County. And, you know, we're just very fortunate to have him on the team.
Oh, that's good. And then, of course, I get to work with him as my boss over there at Broward Sheriff's Office, and just been a terrific person to work with. So I want him to do. Say again?
Another than after what this is for.
I'm sorry, say that again. Must have been someone saying something really important. Hello? All right. So anyways, with that, I apologize. I want to, without further ado, bring in Dr. Jim Roach to talk about something I call EMS meets Leviticus, which I'll explain to you. And this is the rationale and the strategies for bringing whole blood to the pre-hospital setting. With that, let's take it away.
Hello, everybody. My name is Dr. James Roach, and I'm the Chief Medical Officer for the Broward Sheriff's Office. And I was asked by the folks at the Clincon to put together a lecture on implementing whole blood resuscitation program. So before I get started, I just want to say thank you to Dr. Paul Pepe for his help in getting our program started. Thank you, Dr. Pepe. So let's get started. The evolution of resuscitation. Whole blood dates back to probably before 1800s, but definitely in military settings, we gave whole blood in the 1800s. We kind of went full circle. We started giving component therapy and crystalloids in the 1970s in the Vietnam War. And here we are back now in the 2020 timeframe. Whole blood has reemerged and has become popular, and for good reason. So question is, right now, if you have somebody a patient in hemorrhagic shock, what is your therapy that you have that's going to increase their chance of survival? When you think about that, you ponder, the truth is, we don't really have something in the pre-hospital setting to resuscitate someone in traumatic shock other than normal saline. And we know normal saline is not beneficial in hemorrhagic shock. So let's talk about the therapies we do have. We have bleeding control. So we can do tourniquets, junctional packing, pelvic binders, Reboa in the hospital. Of course, surgeons can stop bleeding in the operating room. We can do blood tests to see if they have bleeding disorders, which is called a TEG. We can give tranexamic acid in the hospital. But these are bleeding control measures. And so the question is, what benefit have these had? This trial looks at between the time frame 2005 to 2012. And in this trial, there was a 10% roughly reduction in mortality and hemorrhagic death as a result of bleeding control. So we know bleeding control is definitely something we want to be doing regularly. Okay. For the purposes of resuscitation with blood products, everybody wants to know, what is the randomized control trial that supports whole blood? The truth is, there's really not a lot of data on whole blood resuscitation in the pre-hospital setting. So we have to use other trials. This is a trial from JAMA. This trial looks at pre-hospital blood products, not specifically whole blood, and it shows you a reduction in mortality at both 24 hours and at 30 days. And you see a 14% reduction at 24 hour and 12% reduction at 30 days. So we know in this trial, this supports blood resuscitation in the pre-hospital setting. This trial was from the New England Journal of Medicine in 2018. This was a plasma trial. This trial showed about a 10% reduction in 30-day mortality when patients in hemorrhagic shock received plasma. So these two things are definitely helping make a good argument for resuscitation of blood products in the pre-hospital setting. So you may ask the question, why is this not done more often in the pre-hospital setting? And the bottom line is,
There's fear of litigation. There's fear that we're going to hurt a patient, that we're going to get sued. And in general, people think transfusing blood is something that's done in the hospital typically. And to make that leap to the pre-hospital setting, it's a change in mindset. So the fear of transfusion reactions, the fear of exposing a woman of childbearing age to Rh positive blood and her developing antibodies, these are things that are definitely concerning, and there's things that we need to address. So to address the idea of Rh factor, this is one of the concerns. Let's address it. So when you looked at the San Antonio data, they extrapolated it would take about 250 years of transfusions to get 100 Rh negative women of childbearing age O positive blood. 250 years you'd have to transfuse to get 100 women. And if out of the 100 women that received O positive blood, between 3 and 30 of them would develop antibodies. So not everybody that gets the blood will develops the antibodies. Okay? And I just want to make a point. If my daughter is in a situation where she needs whole blood and developing antibodies is the worst part of that, but she's alive so I can hug her and see her every day, I will take that chance. Now, component therapy versus whole blood. I wanted to give you a side-by-side comparison so you could see what is 1 unit of whole blood, 500 milliliters, versus a 3-component therapy. And you can see hematocrit, platelets, coagulation factors, and the fibrinogen. Here is whole blood side-by-side so you can see the 3-component therapies versus the whole blood, its color, its context, and the size of each unit. Now, what do you need to do to put this program together? Well, you don't need a helicopter. You can if you have a helicopter like we do, we put it on our air rescue and we use it for air rescue trauma. We're also looking to put it into the ground units, and specifically ground units that have the most trauma. You definitely need paramedics, and in between the 2 paramedics is the blood box, which is a cooler. That's a brand name, and there's other brand names. There's also the QuinFlow, which is our rapid warmer and infuser. Highly recommend both of those. Here's the blood box opened up so you can see inside. Here's a unit of our whole blood with the green button on it right there. If the blood gets above 8 degrees Celsius, the center of that button turns red, and we know that blood is no longer safe for use, and it comes out of circulation. Here are the inserts. These are the cooler inserts. They come out of the freezer, and they'll go into the cooler. They last 24 hours. Here is the Y tubing. Y tubing is not 100% required, but it does help prime the line, flush the line for the whole blood. So it's helpful. Here is a freezer and a refrigerator. You don't have to have this level of quality, but you definitely need a freezer for your cooler inserts to keep them frozen. This is also, you need criteria. You need a protocol, right? And so you need to know what are the specific criteria, and you can read these. These are our criteria specifically for when patient meets criteria to give whole blood in traumatic hemorrhagic shock. This is our rapid infuser and warmer. This is the base unit here and the disposable unit. That's how the QuinFlow works. It's very straightforward. And lastly, I just want to mention, when you put a program like this together, you need buy-in from all the stakeholders, police, fire, community people, hospitals. If you can develop an exchange program with your trauma centers so that, your blood doesn't go to waste. Blood has a 21-day shelf life, so you want to be able to exchange that blood 10 to 14 days so the trauma center can use it and you don't waste the blood. And then a tracking system for your whole blood so you can check your data and see where things are, how your effectiveness of your program. And lastly, bringing in the non-trauma hospitals as well is important, because you're going to be giving whole blood not just for trauma but for medical reasons like GI bleeds, vaginal bleeds. Those medical reasons are also very common and can benefit greatly from whole blood. So lastly, I just want to say thank you for the opportunity to share this information. My name is Jim Roach, and I'll give my contact information. If there's anything I can do to help you implement your program, please feel free to call. Thank you.
Great job. I don't know. Hey, is Jim on the line with us now by any chance? Do you see? I don't know if we got him on, because I know he had a busy morning working, again, as the director of the emergency department over at Weston. He's been just, at the Cleveland Clinic. He's just been really busy. He's had a busy year too. He was over in the Middle East helping out, and I don't know. They must clone the guy. I don't know what's going on. So anyways, the issue about the bringing blood to the field is that it just doesn't happen overnight. And I think the thing you brought up was the Brothers in Arms program was really pretty cool. I think that's where the success came from. And a lot of first responders would donate blood for this. And when they found out that he's part of the 75% that had low titer O positive blood, they would actually become part of this program. Most people did volunteer, and so they've had a pretty good source of blood. And I think what's very, very cool about this is that they were able to do it at a relatively cheap rate, and we think it's going to save lives in the long run. And most importantly is for the last 40 years in trauma care, it's always been mechanical approaches to stop bleeding, putting pressure on it, eventually tourniquets, or get them to the hospital where we can operate it and get physical control. This is getting us into this realm of control of bleeding without mechanical means by helping the clotting happening here. And this is we could go on all morning. I'll talk about it later. But one of the things I want to alert everybody to is that along the lines is that what Jim wanted to also do was also provide TXA at the same time. And that's been somewhat controversial in some people's minds, but you'll see in about 2-3 weeks from now, I think it's August 18th, JAMA, there's going to be a very, very interesting paper that's going to come out in JAMA regarding TXA and the use in TBI, and you're going to be impressed with when you see the results there. And again, shows that Jim's way ahead of the rest of us in this approach. So, all right, Chrissy, anything you want to add to that, or what do you think?
I mean, I think that it's very important for us to coordinate with the trauma centers, and that's something that we're doing in Osceola County is providing blood on the heli transport. But to take it the next step is just I think exactly where we need to be going, with the whole blood.
Yeah, his explanation also right up there about when you compare the the getting platelets, the fresher plasma, whatever, and it's not even as effective as giving the whole blood. Like, why don't we? And it's a lot simpler too. Ask any nurse has to infuse this stuff in the emergency department. So this is very cool. This kind of this new breakthrough showing that low titer will work and not cause problems. And I think that's very, very exciting. So anything else to add to Ken before we move on to our next speaker?
Yeah, I'll tell you, go figure. If you leak out red stuff, you should put back in red stuff, not clear stuff. Who would have thought of that? So I applaud Jim for his work in this. Our trauma surgeons locally in Palm Beach County and all across South Florida are very much interested in this. I'm sure our colleagues will find that their local trauma surgeons are interested in pursuing this as well. But obviously, this is a big system you have to develop, and you need the cooperation of the hospital so you can swap out those units that are about to expire and not waste this precious resource. But I applaud Jim for getting this thing off the ground, and I think it's going to save a lot of lives.
Yeah, so with that, the lead-in that I had here before was to point out that we are now looking at, how would you say, pharmacological or infusions to stop bleeding. So our next speaker, Colby Redfield, is going to talk a little bit more and drill down in some of the arenas I was just mentioning. And then Colby pretty well, don't you, Ken? If you don't mind, you want to introduce him for?
Sure. So Colby, for those who don't know, Colby actually works in Tallahassee. He's actually been on my team for advising the Emergency Operations Center on various COVID stuff. So he's been really a great help in bringing subject matter expertise to the COVID thing. But his background, he's went to Florida State, so he's obviously very brilliant. Another Seminole that we got on our panel here, which is great. He board certified in emergency medicine and EMS. He had another one, and he was trained in one of the Harvard-affiliated emergency medicine residencies at Beth Israel. But one of the interesting about Colby, he's a very interesting guy. He was actually deployed in support of Operation Enduring Freedom, where he was embedded in one of the tactical teams as in the capacity of damage control surgery team member. So he can give you some stories about that stuff. He's quite an interesting guy, very bright, and I think he's going to give us a really good talk here.
And he's the medical director over Gadsden County, isn't he? If I remember.
Absolutely, Gadsden County, absolutely. And even in areas where he's not medical director, he helps a lot of those rural counties with free lectures and keeping them up to date on the latest. And certainly Tallahassee Memorial Hospital, where he works, is the assistant medical director of the ER there. he interacts with a lot of, they're a hub for a lot of the area EMS agencies in several rural counties around Tallahassee. So he has a lot of outreach in the north part of Florida.
So to give you a heads up, so to speak, we're going to be talking a little bit about clotting issues in the next little while. That bleeding thing was a good lead into this. And so I call this particular one Allotting the Clotting, the pros and cons of pharmacological bleeding control. And with that, without further ado, let's get Colby Redfield on to talk about non-mechanical but pharmacological treatment.
Hi, my name is Dr. Colby Redfield, and today we're going to talk about drugs that help with hemorrhage control. I have no conflicts of interest. I do not make any, I don't receive any funds from any drug company or pharmaceutical company. Hopefully someday that might change. In the past, our major advancements in trauma care have come during wartime, starting from the Civil War, progressing through Vietnam, and currently with our conflict in the Middle East. This study here looked at a 10-year period of casualties in combat. And what it demonstrated was that 24% of casualties potentially were survivable. It looked at about 4,000 deaths, and of those 4,000, about 1,000 of them they classified as potentially survivable. And so for me, I want to take a deeper look into this and focus on the areas of potentially that we could have to save these people. And when you break down that 1,000 patients, what you see is that the vast majority of them die from hemorrhage, which kind of surprised me and was shocking to me. As with most EMS medical directors, we have limited budgets, limited amount of time to train. And so if I'm going to focus on one area that got the biggest impact for my services, I'm going to start focusing on hemorrhage control. And this is what kind of leads to our talk today. So we're going to talk about a drug called tranexamic acid and its use for trauma and bleeding control. The initial trial kind of came out back in 2011. It was the CRASH-2 trial. The CRASH-2 trial was a randomized placebo-controlled trial. It involved 40 countries with 247 hospitals. It randomized TXA versus placebo with an initial TXA dose of 1 gram over 10 minutes, followed by a maintenance dose of 1 gram over 8 hours. This is kind of traditional tranexamic acid dosing that you see currently. The follow-up was 4 weeks. Due to the lack of time in these lectures, I'm not going to go into much detail on these research studies, but I do want to point out some things. This trial demonstrated a 1.5% decrease in all-cause mortality when given TXA versus a placebo. Now, when you design a drug to help stop bleeding, one of the biggest concerns that we see is that you have an increase in vascular occlusive events, such as MI, stroke, and PE. Fortunately, CRASH-2 did not show any increase in these events, which means the drug was safe in this population. One thing that the CRASH-2 trial showed that time does matter. And with that, it showed around the 3-hour mark, you actually had a signal of harm when this drug was given. Before 3 hours, it was safe. And because of this, most protocols have a contraindication given this drug of 3 hours. Now, anytime you do research, there's always going to be criticism. One of the biggest criticisms of this trial is that some of these hospitals were located in areas that were third world countries that didn't even have a phone to allow for randomization. Now, does a third world country equal this? A modern healthcare system with a robust EMS system and trauma care? We can all agree that that's not the case. A second criticism was some of these patients took extended amounts of time to get to the hospital, even over 8 hours. If you have a major trauma and you're not dead within 8 hours of the injury, is it really a major trauma? Again, these are all valid criticisms of the CRASH-2 trial. The next trial to come out was the MATTERS trial, and it came out in 2012. The reason why this trial got me excited, it was a military trial, and what is a military full of? Our typical trauma patient, young, healthy males. And because of this, I think this trial is more in line with what we see here in America. And this was a retrospective review of one base over in Afghanistan. And what it did was its first half of its deployment, it didn't have TXA or didn't use TXA. and in the later half it did, and it just looked at those patients. And what it demonstrated was that TXA had a significant reduction in mortality. And the one thing here that I noticed was that the sicker the patient, the bigger that difference in the outcome. Now, I guess the big question here in the room is, why is this an EMS drug? Why do we care that it needs to be given in the pre-hospital realm and not in the trauma bay? And this is why. In 2018, the Lancet did a meta-analysis of 40,000 patients that got TXA. And what it demonstrated is time of initiation is crucial. The longer you wait to give TXA, the less effective it was. And to me, that means that this is an EMS drug. Some of my rural counties have over an hour transport time to a trauma center. That's a huge amount of time lost to give this drug. Also, TXA is relatively cheap compared to other drugs and doesn't have any issues with storage. All this make it a great EMS drug. Now, in the CRASH-2 trial, there was some signal showing that intracranial hemorrhage size was smaller in the TXA group. Because of this, CRASH-3 trial came about, and this was released in 2019. And its goal of this trial was looking at traumatic brain injury patients that either had a GCS of less than 13 or had a bleed on CT scan and had no other signs of major extracranial bleeding. And again, the 3-hour window was in there as well, which I showed could cause harm later. Unfortunately, this trial's primary outcome did not show any difference. The one thing that this trial did show, though, was that there wasn't an increase in vascular occlusive events, again, showing that this drug is safe. Now, my theory about why CRASH-3 didn't show a benefit in this primary outcome is the Goldilocks principle, right? Not too hot, not too cold, just right. We all know that if you have a GCS of 15 and you have a small intracranial hemorrhage, is TXA going to make a difference? And on the reverse side, if you have a GCS of 3, I think the patient's outcome's kind of already decided, and TXA is not going to be able to help that patient. So we just kind of want to look at that right population. And some of their secondary outcomes showed some signs that TXA might be beneficial. And one of the things I think we need to look at is that GCS range of like 7 to 13. I think we'll see that benefit of TXA there. Now, he's talked about the future. The NIH sponsored a trial done through the ROC Consortium. It's a placebo versus a 1 gram bolus with a typical maintenance dose versus a 2 gram bolus and no maintenance. And it was looking at the TBI patients, and they were given pre-hospital this TXA. One of the things that this trial had was about a 46% of the patient population did not have an intracranial hemorrhage, and almost set up a group as a safety profile built in. Currently, it is waiting publication, and the rumor is that's going to come out next month in JAMA. Our co-host, Dr. Paul Pepe, is actually one of the co-investigators, and hopefully he can shed some light on some of the results, which may have significant impact in our future use of TXA. So in conclusion, TXA has shown to decrease mortality in the bleeding trauma patient. The use of TXA has never shown an increase in vascular occlusive events. Time of administration of the drug does matter, and hopefully Dr. Paul Pepe can give us some more information on the currently unpublished data from the ROC Consortium. Thank you.
Okay, good. Well, thank you very much. Okay, I can answer that, I think. So first of all, the NIH study, I want to say why this is going to be important is because we've heard there's been publications already such as the CRASH-3 study that actually looked at TBI, but it was only mild to moderate cases, and it did have an improvement, but it's like, the question is like, what if you're really hurt? And as Colby pointed out, in the NIH ROC study on TBI for TXA, 2 things happened. They actually compared the 2 grams right up front to 1 gram and then a 1 gram infusion over 8 hours, which I've never understood physiologically because you should have control of bleeding or have taken care of the problem by that point in time. And then of course, placebo. And the second thing is that it really looked at those with moderate to severe head injury. As we just heard, 56% of these people had a major space occupying lesion, like bleeding in the brain, okay? And that was a group we want to look at. And as he said, because 44% didn't get it, you got to have a built-in safety group there. And so that's what's kind of cool. And I can jump ahead. This will be published on the August 18th issues of JAMA. We are supposed to keep that embargo, that information. However, this has been presenting in some forums, and I can just tell you ahead is that 2 grams is going to end up front, which makes more physiological sense, is going to end up being very, very helpful. The article, when it comes out, it's not going to look like there's any difference because you broadly look at everybody lumped together. But if you look at the subgroup that they talked about this up front, they didn't do data dredging. The group that got the blood, had the bleed in the head, that got TXA are going to end up being very successful here. And again, I can't give all this information away at this point in time, but I think it's going to be a breakthrough study. I want you to be looking at this. It has been so impressive so far, these findings, that the Army, not just the Army, I guess the armed forces, like the TCCC, has already adopted this. And they've actually adopted not just for head injury, but also for all bleeding, upfront 2 grams that is given under these cases. The biggest point of this, if you look at the CRASH 2 study, the original one that looked at it in bleeding patients, if you take it at face value, what was important about it is that the earlier you gave it, like within an hour, the much better the outcome. But if you gave it late, it had more problems and you had worse outcomes. So I think the big issue here is that's why pre-hospital care is so important here. In infusion early on, my mantra has always been the earlier the intervention, the better the results. And this is one more example of that. And so be aware of this, be ready for it when it comes out, and be looking at it, because I think it's going to change how we practice here in the state in the pre-hospital arena. Okay. So with that, you have anything to say or add to that, our other co-host, Ken, before we go to the next talk?
No, I think you did a really good job summarizing all of that stuff, and I know we're a little behind, so we want to get going. Colby is really obviously a great speaker, a great asset to us, and I think, like you said, I'm anxiously awaiting the new study. I think it's going to be a game changer for EMS, especially when it comes to head bleed and TXA. But I guess we'll just have to wait for that study to be officially published.
In the past, TXA was used in a setting where they go to a trauma center, they do a thing called TEG, which we're going to hear about next, thromboelastography. And TEG sort of looks at your blood. You're going to see in more detail how it looks at your bleeding parameters and so on. And if you're clotting or you're hypocoagulable or whatever, and it takes a look at that. It's a really cool tool, but it's used primarily for trauma. What we're going to do next, though, is look at and by the way, an interesting point regarding TXA, people would do that first and then see what it was. Then they decide to give the TXA. Well, now you're way, in the distance, and it's not early on. So I think it's going to have this study that's going to come out. It's going to be great because it's going to change that practice early on. And people have complained that it might interfere with the TEG, but it doesn't matter if you've saved lives and you've made a decision to give it up front. So they'll have little controversies about that. But TEG has turned out to be pretty interesting in COVID. A group of people down in the Hollywood area, namely Memorial Regional, started seeing a coagulopathy with people, but it was also with the people in cytokine storm. And so the prothrombin times all the classic measures, D-dimers were all flaring up in everybody. So they decided to drill down a little further and look at the coagulation status, because that could have been just the inflammatory response. They wanted to look at it. So they used TEG in COVID patients. Well, they found some interesting stuff, and you're going to like this. So the question is, how is TEG and how did the experience in trauma lead to a better approach to taking care of people with COVID? So with that, our next 2 speakers are going to be Michael Estreicher, who just recently published a paper. For those of you who can see this, it came out today in the EMS World. Here's the EMS World Journal, right? I got to get off my screen thing, I think. But any event, if you can, it's called Spotting the Clotting. And he's the lead author on this, and he's going to talk about how they came about this. And I think that there's a component called platelet mapping, and I think we also have Randy Katz from the same institution, and they're respectively the assistant medical and the medical director for Hollywood Fire Rescue, and they will talk about the role of using TEG, T-E-G, with platelet mapping in COVID. So with that, without further ado, can we put the roll it for us if you give us our video?
Good afternoon. This is Randy Katz. Thank you for allowing us to share some valuable information today here at Clincon. The lecture today is titled Spotting the Clotting, the use of TEG with platelet mapping in trauma, COVID, and beyond. Both Micah Stryker and myself are board-certified ER physicians. We're both EMS medical directors here in South Florida, and we work in the Memorial Healthcare System in Fort Lauderdale. Both work at a level 1 trauma center, COVID receiving hospital. We do have one of the largest COVID censuses in the South Florida region, and things have been extremely busy the past few months, to say the least. So initially, we started looking at TEG with COVID patients, but I want to talk a little bit about TEG in general for those that are not familiar with TEG, and really just answer a few simple questions. You know, what is TEG? How can we apply TEG to our clinical practice? And then how does TEG with platelet mapping help us manage coagulopathy in COVID-19 patients? So the first question, what is TEG? TEG stands for thromboelastography. And anytime a clot forms, there's a certain elasticity to that clot. TEG is basically a study that's run in a machine. You can see here on the upper left, it's a small machine. Blood sample is taken from a patient just like any other blood sample, placed in this machine. And this machine gives you a reading. Now, you'll get raw numbers, which we'll go through in a second, but there's also a curve or a graph that essentially needs to be interpreted as well. Why do we use TEG? You know, we have all these other things like PTT, INR, platelet counts, fibrinogen levels. You know, what do we need TEG for? And how is it different from some of these other lab studies that we typically use? Well, TEG is really a more complete picture of clotting, whereas PT, INR, a platelet level, you know, if your platelet count's 150,000, that may be a normal platelet count, but that doesn't necessarily mean the platelets are functioning normally. Fibrinogen levels sometimes are late findings in DIC. Things like D-dimer, we know specifically in COVID patients get extremely high, and we don't really know what's the difference between a patient with a D-dimer of 1,000 and 100. The TEG really gives us a full picture of the clotting system, where it's at. It looks at things like platelet function that we don't necessarily gather from a lab test we can do rapidly in the emergency department. It also looks at the fibroanalytics system, which we don't have lab studies that really look at that directly. And it also looks at things like factor VIII. PT and INR really look at, you know, the intrinsic and extrinsic pathway with PTT, but there are some factors that are not really evaluated by PT and PTT. So when we use TEG, specifically TEG with platelet mapping, we're looking at the functional ability to form a clot. So we're looking at the whole picture and how effective the blood is at that point in time forming a clot for trauma or other things. What are the limitations of TEG? And there are limitations. Number one, you have to have the hardware and you have to have a lab that supports this. So there are not a lot of healthcare centers around the country that have TEG capability, but it's becoming more and more commonplace. And you'll find TEG in trauma centers and large academic centers right now. But TEG will become more and more prevalent in emergency departments and hospitals around the country as time goes by. But it does require special hardware, a special machine. There's specific software that's required to interpret these results. So it does require a fair amount of front-end investment, which a lot of healthcare systems have not done yet. The interpretation can be a little bit difficult at times, you know, especially early on learning how to interpret these curves. I'm going to go through a little bit of what it looks like and how difficult it is to interpret, but you'll see from some of the slides that we have how this is not just a black and white test. This is a difficult test to interpret at times. And you do need ongoing measurements. So, you know, you can do a TEG on somebody on day 1 and day 2 or 3 have a totally different picture depending on the patient's physiologic status. So it does require ongoing testing and blood sampling and evaluation of TEG as time goes by. So this is a graph up top. You know, this picture up top is your typical picture. It looks a little busy. It looks a little intimidating, but you know, this curve, you know, basically from point A here, the beginning of this R segment, then there's a K, which is basically another time segment and there's an angle of the formation of the clot. And then what we call the MA, which is basically the distance between these 2 points. And the LY30 is basically the percent lysis. So you get a value called an LY30. So these are really your value points that you need to evaluate when looking at a TEG. So you'll get this picture up top of a curve, which comes out in a graphic format. And then you'll get raw numbers for the R, the K, the MA, and the LY30. And as you can see below, the R time is really your initial clotting formation time. And there's normal values between 5 and 10. And if that value is abnormal, you need clotting factors. You need FFP. The K time is the achievement of a certain clot firmness. And firmness of a clot is really determined by fibrinogen. And in patients who have an abnormal K time, they may require cryoprecipitate. And the MA, which is extremely important specifically in COVID-19 patients, is this distance between these 2 points, which really indicates platelet function. And that MA can indicate, you need platelets or even sometimes DDAVP as an indication for treatment. Here's a nice picture that shows you all of the different morphologies of these, different TEG values. When you get these numbers, you'll get a picture. And as you can see, there's different morphologies. These black graphs up top indicate normal hemostasis. This is what a normal TEG in a normal person who has normal clotting looks like. In a patient with hemorrhage, you may have a very prolonged initial clotting phase, meaning they need FFP. Patient that has a very wide MA may be hypercoagulable. And then you have patients down here who may be fibrinolytic. There's primary fibrinolysis and secondary fibrinolysis, but these are very ominous looking graphs. When you see these types of things, it's usually a very ominous sign that the patient is not going to do well. So where can we apply TEG? How can we use it? Well, in trauma, we've been using it for a long time, specifically in patients that have hemorrhagic shock or patients with intracranial hemorrhages. Sorry about that. Oh, I don't know what happened there. Let me just advance. Sorry about that. Little malfunction. So patients that have hemorrhagic shock, intracranial hemorrhages, we use it a lot in transplant surgery and cardiac surgery. So for instance, a patient on Plavix who needs bypass surgery, they may want to wait 5 days. Traditionally, that was sort of the gold standard, wait 5 days, do surgery. But if you can perform a TEG and show that the platelets are not malfunctioning and an MA greater than 50 may indicate the patient's ready for surgery much sooner. In obstetrics, we have HELP syndrome, postpartum hemorrhage. Those are conditions that TEG becomes extremely helpful in. And then what about COVID-19? COVID-19, sort of opened the door to us looking at TEG, and I'll talk a little bit as to why. I'm going to hand it over to Mike, a striker, and he'll talk a little bit about COVID-19 coagulopathy, which I think most people are familiar with, but there are some applications with COVID-19 that we're finding. Go ahead, Mike.
Thanks, Randy. So with regards to COVID-19, one of the early findings that we started seeing, in addition to all the respiratory problems, was a coagulopathy. And specifically and more commonly, we were seeing a lot of blood clotting. In the early autopsy reports that were coming out, they would look at thin slices of the lungs, and they would see very small clots in the small vessels in the lungs, in kidneys, and tissue, and all sorts of places through the body. In coagulopathy, in COVID-19, we're commonly seeing things like elevated D-dimer, fibrinogen, and CRP. These are inflammatory markers and also markers of coagulopathy. What's happening, we think, is that there's a endothelial dysfunction, which is basically the endothelium is the lining of the blood vessels, and the virus is able to attach to the lining and mediate injury to the lining, causing an inflammatory process and setting off the coagulation cascade. In the very far and worst cases, it ends up causing DIC and thrombocytopenia, which can be seen as in both cases of widespread clotting and also bleeding. Reports have come out through the past 6 months or 7 months showing increased rates of pulmonary embolisms and DVTs. We've seen increasing rates of strokes, also even in young people as well. We've seen people going into renal failure. We've seen weird rashes, things like rashes like on the toes, for example. And when they look at the tissue, they see basically small clots in the microvessels of the tissue, and that's what's probably causing what looks like the rash. And then we've also seen bleeding complications like intracranial hemorrhages and things like that. So we definitely are seeing a widespread variability, but I would say the most common is hypercoagulability, or meaning more clotting. So what we're looking at now is a hypercoagulable patient. This is a typical COVID patient that we're seeing. In fact, this is a COVID-19 patient. And if you look on the top at 4/17, 2020, that was day one when they came into the emergency department. And basically the person was well balanced. If you look, the R value was 4.9. And then we most commonly look at the MA on the right, AA specifically, which kind of looks at one of the platelet pathways, and that was 41. Generally speaking, if we have a R of less than 5, or I would say an R between 4.5 and 6 or so, that's kind of in a balanced state. So he's good on that end. And when you have an MA in the range of 40 or so, you're in a balanced state as well. Now, as his disease progressed and the patient was in the hospital, when we repeated the tech on day 4, the R went down to 3.7, meaning he was clotting faster. And his AA went up to 71, as you can see, and meaning his platelets were more hyperactive. So basically the platelets were more sticky and his factors were more hypercoagulable. So this patient basically needs normalization of both of those. And in this case, we would give Lovenox and we would give aspirin to help balance that out. Now, if you go to the bottom, initially this patient was hypercoagulable at 76.5, his AA was, and then his platelets were very hyperactive. And then basically he received aspirin and his AA went down to 40.6, and we would maintain on that regimen. In another instance, we had a patient who was actually hypocoagulable, meaning more prone to bleeding. This patient was really sick, and if you look at his LY30, it was 19. Basically, this patient is lysing and is very prone to bleeding. And if it's thought to be due to something like microthrombi, for example, thinking that, oh yeah, he's really sick because we have a lot of blood clotting taking place, there were some places that were giving TPA to break apart the blood clots. But in this instance, if you would give something like TPA, it would have really led to severe hemorrhage and for sure death. And then in the bottom, we have another case of a patient who comes in, and he was needed to be left in a more hypocoagulable state because he had vascular stents. And we know from COVID-19, a lot of these stents, ECMO lines, dialysis lines are very prone to blood clotting. So in this patient, it was actually important to leave these stents open. And if you give even full anticoagulation in a case like that, he could bleed. So I think what we're really seeing here and what we're learning is that COVID-19 and blood clotting or bleeding in COVID-19 is a very individualized process. And TEG has provided us with a way to individually manage these patients. So looking here, this is an algorithm that we developed at our institution in order to help guide therapy. So taking, for example, on the very top, when the patient comes in, for example, if the patient's R value, which is what's looking at their factors, is less than 4.5, and their AA is above 45, all on that first line, then you end up in the far right box, solid red there, which is basically to institute Lovenox and give aspirin. This is because he or she would be in a very hypercoagulable state. Whereas on the other flip side of things, coming in, if the patient's R is higher than 6, meaning he's more likely to bleed, and the platelets are really low, or the AA, is really low, less than 30, then you would definitely either not give anticoagulation, or if there is one already being given, you would hold the anticoagulation and as well as the antiplatelet. Generally speaking, the AAs greater than 50 are what we have been seeing that are driving thrombotic complications, clotting type complications. And when the R value goes above 8, that seems to be driving more of the bleeding complications. In our study, which hasn't been published yet, we do have some preliminary findings we'd like to share with everybody. And we basically prospectively looked at 65 COVID-19 patients who were admitted with moderate to severe disease through our emergency department. And on each of these, we performed a TEG with platelet mapping at the time of admission. And then we repeated the TEG around 48 to 72 hours later, depending on the clinical condition. And what we found was most patients either had hypertension, diabetes, hyperlipidemia, and were male. About 1/3 of them went to the intensive care unit. And there was improved survival, decreased rates of mechanical ventilation, and lower incidences of acute kidney injury. Specifically, in the coagulopathic TEG group, they were more likely to have ICU admissions. They had 40 times about rates of having or needing mechanical ventilation, 33 times needing dialysis, and their death rate was about 13 times higher than the non-coagulopathic TEG group. So basically, what we're seeing here is the role that TEG is able to play and support our management of the coagulopathy in COVID-19. And we really see that it's providing individualized management, and it appears to be having an effect on outcomes in a positive way.
We really appreciate your time, and I've included both of our emails here. If you have any questions regarding our algorithm, our protocol, or some of our study findings, feel free to email either Mike or myself. Thank you for having us.
Thank you very much.
Okay, thank you, Dr. Katz, and thank you, Dr. Estreicher. So that's really interesting in a very clever way, and again, it's showing, I mean, this is, I've looked around the country, and these are the folks that are doing this, and, you know, in terms of leading the way in terms of using TEG in this manner. The limitations are clearly that not everybody has it right now, but I see this in conjunction with what Dr. Roach was talking about before, that TEG could be a valuable thing if someone got smart enough trying to figure out how we could do it as a point of care eventually. It could be very, very interesting for us. But I think what's really cool is it also differentiated between most of the people with very bad COVID are hypercoagulable, and sometimes they're hypocoagulable. So we don't want to empirically treat people unless you know what it is. So this has been very interesting. I think one other point I wanted to bring up is that keep in mind, though, TEG is still a snapshot, and that it has even diurnal variations on a given day. So those are some of the things to keep in mind as you go through this. For my other co-hosts, anything else to add at this point in time, since we need to move on?
Yeah, I think, you know, the clotting has been really a big deal, and Dr. Katz and Dr. Streicher have been great pointing it out. There's one other thing, though. There's something out of Israel about alpha defensin causing clotting, and that's not affected by aspirin or Lovenox, but colchicine can actually help with that. So something on the COVID front to keep in mind is that colchicine may play a role in the clotting issue as well as anti-inflammatory.
Yeah. And that's really good. I mean, it's really clear that the inflammatory response that you get with this is interwoven somehow. I think they're kind of independent, but they're clearly interactive with each other. One causes the other, and I think that's a very, in fact, we don't absolutely know how TXA works. For example, you go back to that one. A lot of people think it was someone's typing right now, by the way, and just so we can hear it. And then people, you know, TXA can be a clotting, you know, think of it in terms of a thing that enhances clotting, but it also has sort of anti-inflammatory processes, and I think they're interwoven. So that's a really good point that you're bringing up there, Ken. All right, anybody else? Christy, anything else before we go to the next speakers?
Well, I just think that, you know, the more information we get with COVID-19, the better we're able to treat patients. And so I think that, and you know, this is really helping us through this crisis right now. So great work.
So once again, state of Florida is taking a leadership role on a national level. So it's going to be cool. I happen to know that this is going to be in a publication that's going to come out pretty soon. And so I applaud them on their work here. All right. So the final speakers that I think we have on the agenda, if I remember, are going to be talking about, as you've seen, we're starting to introduce COVID a little bit. And the next thing is that we're going to talk about a little bit is mass gathering medicine. And even though that's been held up to some extent, there are still other mass gatherings that are starting to take place, and particularly Orlando has been a place that's welcomed in the NBA, and Disney's opening again. So we thought we'd do a little talk called From Daisy, the Electric Daisy Festival. If you don't know about the Electric Daisy Carnival, that it's also been called in the past. From Daisy to Disney, handling masses before and after COVID. So with that, we are going to have Dr. Alexa Rodriguez, who's the Deputy Medical Director down there in Orange County, the Orlando area, and Chris Zuver, who's the overall Medical Director. And I think since you're in that area, Chrissy, why don't you do that introduction for the two of them? They've been really terrific people to meet this year.
Yes, I'm very lucky to work very closely with both Dr. Zuver and Dr. Rodriguez. Here in Orange County and Orlando, I think that we have a very tight-knit group that continues to promote EMS care here locally. And we luckily we were able to bring Zuver back from Wisconsin. It was difficult. He's a big cheese lover, and but we were to lure him back with his wife and kids with Disney and in the warmth. And with Dr. Rodriguez, she tried to get away from us, but we kind of chained her down so that she would stay here in Orange County and continue to be a part of our team.
Yeah, and they're actually delightful, and they've hosted me a couple of times up there, and I just really have gotten to like them a lot, and they're doing some really good things there. So I guess without further ado, we should go on and hear about From Daisy to Disney and hear what they have to say before we go to our lightning rounds.
Hi, I'm Alexa Rodriguez, the Deputy Medical Director for the Orange County EMS system in the Orlando area. And today we're going to be discussing From Daisy to Disney, handling masses before and after COVID-19. I'll be joined by Dr. Christian Zuver, Medical Director of the Orange County EMS system. So in the Orange County area and the greater Orlando area, we tend to handle mass gatherings each and every day, both with our stationary attractions with resorts like Disney World and Universal Studios, as well as seasonal attractions and major events. This is something that we're familiar with tourism being a large portion and drive of our local economy. The specific event that I want to discuss today is the Electric Daisy Carnival in Orlando. It's a multi-day electric dance music festival here in Orlando. There are several other similar events throughout the country, as well as throughout the world in Japan, Mexico, and the largest being in Las Vegas. EDC Orlando started here in 2011. At that time, it was a smaller 2-day festival, bringing in about 10,000 patrons each day. Since that time, it has continued to grow into a much larger event. With the initial stages of the EDC festival, any medical needs were addressed by event staff as well as local EMS response for patients requiring transport. As the event continued to grow in the year 2015, the event grew to the point where it overwhelmed local EMS. It overwhelmed the local hospitals and also led to poor patient outcomes with 2 deaths that year. Since that time, and prior to the 2016 event, we've joined together as a community to address the need for a safer environment for the patrons of this event, as well as our local community, by placing an alternate medical treatment site on site of the event. This has been a joint effort with local hospitals as well as local EMS and the Office of the Medical Director. EDC Orlando in 2019 has continued to grow. In our last festival, the festival moved to a 3-day festival. It grew the number of stages up to 4. It overtook over 40 acres of the venue in the downtown Orlando area, and it had over 200,000 attendees with daily attendance in the 100,000s plus. It's no surprise the draw of this festival to local patrons as well as patrons from around the world who travel here to attend. There are intricate stages, there's quite a bit of pyrotechnics, and there are even rides. while all this brings in a lot of business to the area, it also complicates the medical care being provided at the event for those of us who are planning and attending to those who need medical care. This event is not only logistically but medically complex. There are some tight corridors and the crowds, as well as navigating around water features, rides, and the intricate stages. It can be difficult to access patients at times, and it is definitely a challenge to continue to provide them with a quick field response as well as efficient patient care. Not only is logistically this festival complex for addressing patient care, but also medically, not only due to drug and alcohol use, which evolves each year, but also due to environmental factors such as the Florida weather, the humidity, the heat, as well as the rain. In our alternate medical treatment site, we have 3 specific areas to evaluate and treat patients. We have an area for lower acuity patients with West cots for patients to kind of relax and potentially sober up. We have a moderate acuity area in the yellow, and we also have 6 temporary ICU level care beds in the critical area or the red area. You also notice that we have a pharmacy on site as well as a triage area within our treatment facility. If you look at the following, you can see that in the lower left-hand corner, this would be an example of our green or lower acuity patient area. Moving to the right, you can see an example of our moderate acuity area. And then up in the top left, you can see an example of a critical care level bed. Both levels of monitoring and what we can provide as far as patient care, including supplemental oxygen, increases from level to level. We also keep ice tanks on site. So we have the recovery tubs, if need be, most of the time to address drug-induced hyperthermia. We have used these several times in the past. So as I stated before, this is a community-wide effort to provide such an advanced treatment facility at this event. We joined together with the Central Florida Disaster Medical Coalition, who staffs mostly our nurses, pharmacists, paramedics, and EMTs, as well as logistical support. The Office of the Medical Director for Orange County EMS, and then, of course, the City of Orlando Fire Department, who provides all the field response in the event and around the area. In 2019, our alternate medical treatment site staffing included 5 on-site EMS physicians and medical directors, 33 medical students from the University of Central Florida, 25 emergency medicine resident physicians from Orlando Health, Advent Health, and Osceola Regional. These are our local residency programs, and 12 emergency medicine attending physicians who were in a supervisory role. We were also lucky to have over 50 nurses, over 50 EMTs and paramedics, over 40 paramedic students, and 5 pharmacists on our on-site pharmacy. And this is all within the alternate medical site tent itself. We also have the Orlando Fire Department who's responding within the venue, and they are not counted in these numbers. Ultimately, I think in addition to improved patient care, improved safety, which we've seen, we've also seen a stabilization of our local EMS system during the event with much less pressure put onto the EMS system, as well as decreased transport to our hospitals due to the alternate medical treatment site that we've put in place. I think another great thing that comes from this relationship that we've built with the community is that these physicians, nurses, pharmacists, and students get to experience a little taste of what our pre-hospital providers get to experience on a day-to-day basis. And we can really build around this community. As far as EDC Orlando 2020, yet to be determined, although with the COVID pandemic, not likely to occur, at least in any way, the same capacity that we have in the past. While social distancing would be very difficult, one thing that they have been doing for years at the EDC event is actually wearing masks. So this is potentially something that are more stationary attractions that are revving up again during this pandemic can take from one of our less typical mass gathering events that we address here in the Orange County area. With that, I'm going to go ahead and let Dr. Christian Zuber take over to discuss how the area is responding to the COVID-19 pandemic when it comes to our mass gathering events.
Hi, my name is Christian Zuber, and I'm the medical director for the Orange County EMS system. I work with Dr. Rodriguez here in Orange County, taking care of our citizens. She gave us a good overview of one of our approaches to event medicine. My topic is going to be a little different. I'm going to talk about event medicine in the COVID era, especially as it relates to Orange County. Orange County is a unique location in that we're the home to 3 of the largest theme parks in the U.S. Some of the theme parks are as big as in the world. And COVID has made it very difficult in a tourism-based economy with the lockdowns and the quarantine. And the big question we had to answer here is, how can we open situations for conjugate gathering with the least risk possible to the public and to our local citizens? Universal, Disney, and SeaWorld are all located here in Orlando. And to say they're a major economic loss to our region would be an understatement. Walt Disney World closed on March 15th. And just for some background information, Orlando gets about 75 million visitors per year. And of that, Walt Disney World sees about 58 million per year. And that's averages about 57,000 visits per day. Numbers are not completely set in stone, but that's the running number that we're aware of. Universal sees almost 21 million visitors per year, and SeaWorld 4.6 million visitors a year. So I can comfortably say that we run a mass gathering event every day here in the greater Orlando area. As I said, Disney closed in March, and it closed for 119 days. And just to kind of get an idea of the financial impact, it's estimated that Walt Disney World provides $38 million a day to our local economy, and Universal almost another $11 million. So that's including parks and hotel rooms associated with the attractions, merchandise, and food, everything you can imagine associated with a park. When you think of a family that comes here, park tickets, food, hotels, parking, merchandise, it all adds up very quickly. So this has been a really massive impact on our local community. And Orange County government realized very early on that at some point our parks were going to have to reopen. And at some point we were going to try to find a way to do it as safely as possible. We set up an organization here called the Economic Recovery Task Force. And what happened was that our parks, starting with Universal and then SeaWorld and then Disney, petitioned the county to reopen, to allow us to start bringing visitors back to the parks. The governor wanted to make sure that the local municipalities had some say in this process. So all of these parks needed to have local government approval before the governor would evaluate them and authorize them to open. And the main thing was to follow the CDC guidelines as you can in a conjugate visiting facility like the parks. So our biggest park here is Walt Disney World, and I think I'll spend the majority of the time talking about Walt Disney World. Walt Disney World brought a plan forward to the Economic Recovery Task Force about how they wanted to reopen. And in that plan, which I'm going to discuss some of the key points of it when I talk a little bit about what it means for the average citizen going to the parks now. They came forward with a plan, and part of that Economic Recovery Task Force, and part of my job in that was to be one of the individuals that was responsible for the investigation, or I should say the evaluation of the park plan. And essentially, we had to go out to the parks to see if they could meet with their infrastructure and their supplies what they told us they were planning to do. And this picture's up there because if anyone's been to the Magic Kingdom, it's hard to find a day when there's only 4 people there, but that's the day it was like when we were there. And it's a weird kind of scenario to see the park like that. So the plan went forward. The inspection team came to assess what would that mean if it opened. And on July 11th, the Magic Kingdom opened for business, followed shortly by Epcot, and then Animal Kingdom and and Disney's Hollywood Studios. Not necessarily in that order, but as we speak today, all the parks at Disney are currently open. So what does it mean for me? Well, first of all, I think it means you're entering at your own risk. Disney and everyone around knows that we can't guarantee folks won't be exposed to COVID. What we can do is minimize that risk. And so what do you see? Well, I think the big things you see are the usual things that we're seeing going around the country in terms of risk mitigation. So going into the parks now, everyone gets temperature screened. If your temperature is above the normal range set, you're not allowed to come to the park for the entire day. You're sent away. The other things you see is that our numbers are way down. We have park capacity controls right now that limit the amount of people that can come into any given park. And so you have to have a reservation in advance to get there. Initially, the parks were open to our annual pass holders here, and they've since been opened more to the public. The other big thing you'll see is that on top of temperature screening and limited numbers are the other social distancing things. So first thing we'll say is guests have to wear masks. And there's an exception made for eating and drinking. And we quickly kind of found out that there may have been a couple folks at the parks that theoretically seem to be eating and drinking a lot to get around mask use. So unless you're specifically actually eating and drinking and sitting in one location, you have to wear a mask. The parks also implemented high frequency cleaning in high frequency areas to decrease that. Now, if you look at this picture, you see a temperature check, and then you see the park during the first week on the picture on the left. That shows you the big difference compared to what our normal summer day like at the Magic Kingdom is. So capacity controls have really been a major component of the reopening plan. And here I think you can see some other items related to sanitation. I will tell you that if you go back to the previous slide, capacity control. So the Magic Kingdom is thought to hold about 45,000 people at 50% capacity. The rumor now is that we're operating about 12,000 now. Disney Animal Kingdom's capacity is about 30,000 at 50%. Epcot is about 55,000 at 50%. And Disney Hollywood Studios are at 50%. I say 50% because the parks initially, that was they proposed for initial opening was 50% capacity. They, on their own, decided they wanted to go back. They were more comfortable with lower numbers. And so they started at a much lower capacity. And if you think of, 45,000 being the 50% capacity for Magic Kingdom, now it's around 12,000 a day. It's a big difference. And if anyone who's been to the park when it opens in the morning, Disney says that's about as on a typical day, that's about as crowded as it gets now throughout the entire day with our capacity controls. Things you also see are really increased messaging regarding the park and sanitation and mask and distancing. You can see that within the park, you'll notice there are 6-foot social distancing markers throughout, and there are also numerous areas for hand sanitation and making sure of mask use. There are some rest areas where folks don't need to wear masks, but those are limited and they're distance off. Here, you see a couple things. You see one of the physical barriers that they've implemented on the rides. If you go back and has been to Soarin', you can see in the top right picture, they've put in physical barriers between riders to ensure appropriate social distancing and to try to minimize transmission. Masks are required on all rides at Disney now, even the water rides. Down below, you see a plexiglass barrier where social distancing is harder to achieve in the area like the Ride of Resistance. Those are other physical things that the parks have put into place to minimize exposure of guests. And lastly, you'll see that queuing has changed. No more our fast passes. They're gone. Everything is done by virtual lines and your cell phone based transmission of how that line runs is how it works. Other things that you might notice at the parks that they've done, they've minimized and eliminated actually their character meet and greets. There's no more autograph book signing, and all fireworks shows have been canceled. They've canceled anything really inside the parks that could promote mass gathering, fireworks, parades. Instead, they have pop-up parades where they're very short and they're not pre-announced. And in the background, things with staff. Staff are also required to have daily temperature checks and to use appropriate PPE during the course of their time at work. There's no more trying on merchandise in stores. Most of the merchandise is now offered online. And unfortunately, Disney PhotoPass will no longer take a picture for you with your phone. So that's kind of Disney in a nutshell. We've got a couple of people we'd like to thank for this, but the parks have really undergone a large restructuring in process, and they've changed the way they're thinking about doing things. And it's a constant reevaluation to see what works and what doesn't. And it'll be a flexible process as it goes. There is no way to completely eliminate the risk of COVID to anyone visiting the parks, but I think we can say that our parks are doing the best they can to minimize that risk following the CDC guidelines. So with that, I'd like to say thank you for listening to myself and Dr. Rodriguez. We have a unique jurisdiction here and a kind of a unique view on mass gathering medicine, and I hope that we've been able to show you a small picture of what things are like here on a daily basis.
Okay, well, thank you very much. That was terrific. So it is interesting. Well, we finally did get around to some COVID today, but it's been kind of, I hope today's set of lectures gave you a little bit of insight to some of the unique things and progressive things that are going on in this state, not only in terms of the, dealing with the COVID crisis here at the end, but also more in terms of what we're publishing, what's going to be coming out in publications from this region. It's just the leadership role here in EMS in Florida has just been terrific, and I've been enamored of it, and including the concept, like the classic thing down in Broward County, the Broward Fire Chiefs Association puts on with the First Care, First There conference. I mean, just right there, it's the idea of that we provide care for people, not just management or treatment, and it's been fantastic. So anyways, I hope everybody else can join us. We only have a few minutes left now for the thing that we hope to have been for at least 45 minutes or an hour. Previously of just a roundtable of questions. I think probably at this point in time, everybody's a little bit fatigued from today's talks. We had a lot of them, a lot of information, but you'll probably retain it well as well. And then this is going to be, from what I understand, will also be on a recording, so we can all go back and look at this or restart it or review it again, so which is really terrific. Again, I wanted to thank people such as our president from the Florida Association of EMS Medical Directors, Christy Van Dillen, has done a fantastic job. She's herself has just been a terrific leader for us and has had a tremendous experience, especially in the concept of starting up EMS fellowship programs, helping to get those going and keeping them here, and then producing a crop of future people who've been well trained and have a mentorship themselves from people like her. And of course, our state medical director, Ken Shepke, who has just been a fabulous job here. So I want to open this up to any questions. One thing I actually want to start off with is that if we've got a little chat thing here where you can ask questions. For those of you on the line, if you run your mouse down below, you can probably find an area where it says chat and you can ask a question. But I think first I want to start off, there was a question that came up earlier about ketamine and TBI. And so Ken, you'd probably be the best person to answer that one. What do you think about the use for TBI? And then Bailey, if you were there, if you can maybe expand upon later what specifically you're looking at. Is that a good thing that you just mean in terms of innovating, or just a good thing to do for patients in general?
Well, I think they may be relaying the old myth in medicine that ketamine raises intracranial pressure, but we know better now that it does not. There was an old study, it was flawed methodology, it was in folks where they did not control for end-tidal CO2, it was brain mass, not actually brain trauma. And studies since then have now actually kind of dispelled that myth. Ketamine is perfectly safe in brain trauma. If it either does nothing to the intracranial pressure in those cases, or perhaps in some studies even lowers it. So back in 2011, ACEP actually came out and formally said that it is not contraindicated in head trauma. So I appreciate the opportunity to continue to dispel that myth. So yeah, I think there's no problem with ketamine in brain trauma. And there's some reasons why that actually is probably the first choice. The things that make things worse in trauma is if you make the patient stop breathing, they get hypoxic. Well, ketamine, you keep breathing, which is an enormous thing. And ketamine preserves the airway reflexes, which is an important thing. And I think it's definitely one of the drugs of choice for folks that need to intubate that have brain trauma.
The other question that came up was using ketamine in kids with disabilities, disabled kids. What's been the problem there? What was the thinking that there could be a problem there?
Well, I wonder if Peter's on, because I generally shunt all the pediatric questions to our resident pediatric expert and put him on the hook on that one.
That's right. Well, we'll have to see. He's usually like multitasking, and so on. Peter,
I would say so.
No, I'm here. Hey, Paul. Yeah, Ken, thanks for that. Actually, one of our captains at Palm Beach County emailed me the other day, and he said, "Hey, are we missing something here with kids who have, let's say, are on the autistic spectrum, and so forth?" And I mean, it really brings up a very good question, and I don't think I have the answer to that right now, but I think it does deserve some evaluation as to whether or not, for whatever reason, do kids on that spectrum. But at the same time, we use ketamine for those children in the emergency department. I know I do. Never had a problem with it. I'm wondering if maybe dose related. And I think we're hearing some of that come out of some of the other agencies where they're using quite a high dose, and perhaps that's the issue. But I'm not sure if anyone else on this call has had any issues with giving ketamine to those to children. I mean, we've been using it for many, many years in children without any issues. So not really sure of that answer.
Okay.
You know what, Paul? I had another top one. I missed it. The other thing that makes head injury worse is hypotension. And ketamine's particularly good at preventing hypotension. If anything, it raises the blood pressure in those folks.
Yeah. I'm actually currently involved in a trial looking at etomidate versus ketamine, and I think that's going to be very interesting because that's what the typical approach has been under those circumstances. So I think that's really been a terrific concept. So anybody have any questions for any of our speakers here today about their presentations? We do have Chris Zuber's on live, I understand, and Colby Redfield's on live that can answer some of your questions. Charlie Crand is online. Yes, go ahead, Dr. What's your name again? You are?
Tevi, yeah. So I have a question for Chris, and with respect to Disney World and so forth. It just what is going to be the item that really potentially shuts things down again? I mean, how are they following a potential outbreak in Disney World when people are so transient? Are they monitoring the employees any differently than they're monitoring the actual park goers themselves? It just, when I saw, just quite frankly, when I saw them reopening, I thought, how are they going to control any outbreak, especially when the percentage of infection is so high across the state? So just curious about how they would mitigate any outbreaks that occur at the park.
Yeah, Peter, I think that's the $1 million question. Everyone who, comes to the park is usually going back somewhere else. Now, the beginning parts we've opened were mostly pass holders, but they were throughout the state. The employees are going through enhanced screening, and they're tracking them accordingly, and they do appropriate quarantine procedures. I know that for the most part, the handoff occurs once folks leave the state of Florida and go back to their home communities, or even within the state of Florida, it goes back to their local Department of Health for the contact tracing aspect. And for those who aren't in Florida, most of the contact tracing is done via the county departments of health. So that trade-off is the hard part, is the folks that come and either they were exposed prior and they get symptomatic after they get back or whatever. And I don't think we've as yet known of an outbreak associated with one of the parks since reopening, but that's really in our radar. And I think the best the parks can do is try to minimize those symptomatic people coming in with all the different precautions that they're taking. But we know that we have a asymptomatic group of people out there that can still spread. And I think just from their standpoint, holding to those important aspects of decreased capacity on the rides as well, enhanced sanitary procedures, and of course, mandating masks. I think it's the best you can ask. There's risk associated with any of those parks, as you know, or any public event in general, and where you have large numbers gathering, and this is no different.
Hey, since I'm going to have to shut down here in a couple of minutes, hopefully everybody keep the remarks a little shorter, both questions and answers and all that. But thanks for that, Chris. I really do appreciate it because it's a topical, very topical question, particularly for me, because those are the kind of things I like to do. Charlie, Sand, what happened with the Marlins though at the home opener?
I think you guys in Miami can comment more, but I read four Marlins had COVID positives. They shut down the opener game. Is that correct? That's what I read.
I don't know.
I just read that online today. I always look at sports first thing when I get up.
Yeah, you know what I look at when I first get up? I look at the obituaries to see if I'm in there.
That's a fifth thing. I'm not as old as you are, Paul.
Yeah, that's exactly right. So, yeah, I am the elder of the nations here. So, okay. Anybody else have any other cool presentations? So, I want to know, first of all, Ken asked for Colby, is there any pushback from the trauma on EMS TXA? Do you know from the trauma people?
We actually had a very aggressive trauma surgeon who accepted it right away and loved that we were doing something very proactive. I think we're unique in the Panhandle compared to everybody else, where some of these rural counties can have almost 60 to 90-minute transport time to see us. And so we have at least a tool we can use to kind of help with hemorrhage control. So it was actually very easy for us. We do use TEG as well. There's that argument that TXA could screw up the TEG, but the fact of the benefit of TXA outweighed waiting for a TEG. So we're pretty aggressive up here.
That's good.
Can I comment real quick?
Before you get to that, I do want to say once this article comes out in 2 weeks, it's really going to change the game. Just so you know, Charlie, go ahead.
No, just real quick, after Crash 3 and things came out, what was that, 4 or 6 months ago, I brought it up we're a major trauma center in Tampa. I brought it up. People were interested, but they said, let's wait for more evidence. So thank you for providing that.
Yeah, and the more evidence is really going to be hit hard. And then once they find out is that the military is using it and so on, they'll finally come around. So I think this is an exciting time because it really but again, I'm the first person to say, and I just literally just wrote a paper and submitted it while we were online here, called it was a takeoff from Star Wars, and it said that only a Sith deals in absolutes. Like, it's not that something's good or bad. Even an AED, you would think, of course it's good, but if you don't use it right or put it in the right place, it's not cost effective, etc. So it's the same thing with TXA. You've got to use it early on, or it really doesn't provide it. And it could even be harmful. Just like in ITD, you got to have quality CPR going on, or it ain't going to work, or it could be harmful. So, or like they talked about the head up CPR, I think that you got to do it in a very progressive manner in a certain way, or it could be harmful. So I think that's, if we get that message across out of this state, it would be very, very helpful. So that's great. In any event, I'm trying to see if we have any other. Oh, it's an interesting question. I don't know if Angus is still on. They said, are you going to think about using it for the elderly who have fallen and have head injury? That could be an interesting place for it as well. That's down the line. Are you still here with us, Angus?
Yeah, hey, I've got to go in 2 minutes to talk to my hospitals about Divert, but
what's that? Right. Okay.
But I did actually, after our discussion the other day where that article was presented, start texting with our head trauma surgeon at one of our hospitals, and we agreed to sit down once the article's published and look at the data and see if we want to do anything different.
Fantastic.
Angus, when you go to your meetings, just hold this up.
Trust me. Yeah, exactly.
The CEO loves that.
Yeah, I'm sure. Hey, one thing, I guess, since we are like right at the witching hour here, where we should really wrap up for everybody's purposes. I mean, I'm willing to come on and go on for a little while longer, but I hope that the format that we used here, I mean, take out the technical glitch we had at first, but once we got up and running, I hope that was been useful for you, and we can do this more often. Anybody have any recommendations or suggestions for us, to make this better, et cetera, in the future? And you want us to come on and do live presentations, or should we just keep, was this fine when we did the canned presentations? That's one thing I'd like to know right away. Ken did a good job because he stayed within the 6 or 7 minutes to get the ketamine thing done. And so I just wanted to see what people's feedback was on that.
Well, and for the Florida Association of EMS Medical Directors, we're going to send out a little post educational program survey just to see after we also allow people to have access so that way we can get some feedback, because I really think this is in the right direction of where we want to go. And so we would like to continue, like we said earlier, to have forums like this, continue to collaborate, continue to educate. And so I really think that this is very exciting for me. I think that it's exciting for the organization, exciting for the state. And so I think that maybe if we just did Zoom the whole time and we could still have the recorded presentations, I think the recorded presentations are nice because it gives us a stable, piece, and then intermittently having some other commentary and then a QA session. But if we did it all on Zoom, it would, I feel like that would flow better. And then we'll get feedback, and I think we can do this again, get some other people involved, and keep it fresh.
Yeah, so the feedback I'm getting so far is prepared talks seem to work nicely. And then, a couple of people say I agree with that, et cetera. Definitely send out the questionnaire to everybody, et cetera. And then pre-prepared will keep it from going over. So all this sounds like we should still do that, and so on. And talks will be posted, et cetera. So I think that would be a really terrific. So it sounds like we're on the right track here. This last part worked out okay. The main thing is to make sure our speakers do stay within that, or we just reject the talks. And one of the things that I'm on a couple of major international meetings that are coming up, like where they have 6,000 people in the audience, and they actually are telling their speakers, we're going to give you this 8-minute slot, and if you go over it, we're just going to cut it off. You'll never get your conclusion in or whatever. And so it really, when you threaten people like that and you do it, and people know I do that with the Eagles, I cut the speaker off if they're going over, and then they don't get invited back again, that kind of thing, right? They go, that guy keeps going over all the time. So we'll try to do that. But I think everybody did a really good job. And that's the other thing I wanted to say before we got out. A lot of people put a lot of time and effort, and I know that, and personally was witness to a lot of time and effort. Jim Roach tried to get his talk down. He had 14 minutes, etc., and then he came back and got it down to 7 minutes. And so there's a lot of time and effort to be succinct and get it across. But that way we had more speakers, we had more topics, and it just was. I learned a lot this morning. So if we hadn't had the big technical glitch that shot up about half an hour of our time, a little bit more. This might have been just really a really cool, seamless organization today. And love the commentary from you and Chris, by the way, so I wasn't up here alone. Appreciate that, Ken. Okay.
Sure.
All right, anybody else have anything? We got here commentaries by Paul should be included, was still great. All right, good. Great job. Great job. Enjoyed. Thanks, staff, for working out the technical issues. Yes, absolutely.
Yeah, Paul, if I could comment on my comment. I meant that when it's sent out to FAEMS, MD, and all the other groups, your guys' commentaries were phenomenal.
Okay, good. All right. And will that be included in, because this is all being recorded, so I think the whole thing is being recorded, if I remember correctly.
Okay.
I hope that's the case. We'll see. Okay. So I hope that's the case. Yeah. And so it says here, well, thank you, all of you, for joining us today. Any from the persons who are organizing it at EM, the Clincon folks, any comments from you guys or any closing statements from you? Maybe not, right?
Well, we got the text from Melissa saying, thank you for joining us today. So I think that's their comment.
All right. So all right.
I was just going to say thank you to them for all the work that they continue to do for us.
Yeah. So I think that overall, this was really cool. I love the fact that this really did highlight that a lot of the major publications, major studies coming out in a lot of these areas were coming right out of Florida. I'm very proud to be associated with you. And Chrissy, is there any news about me and the Florida Association of EMS Medical Directors that you can announce?
Yes, our newest member to the Florida Association of EMS Medical Directors is the famous Dr. Pepe.
More infamous, right? Yeah.
But we finally caught him. I mean, we stole him from Texas. So
Wait a minute. How do you get past the acceptance criteria? I'm not so sure about this.
Yeah, you have to be under the age of 70?
Technically, he's still in quarantine.
Welcome to Florida, Paul.
Yeah. And then my PPMI is pretty high. My the Pepe Pun Pyramidal Index is still keep it up. No, but listen, thank you very much. I'm really honored to be part of this group, and I mean, I'm just enamored actually of both the chiefs, the paramedics, the medical directors. I just have a great progressive and collaborative spirit. That's what's been really terrific. So All right. Well, anyways, someone said I got to get. I like this. Carrie one said I got to get Paul a Florida hat. Okay, I'll work on it. Actually, I've got a couple of them, but they're down in my place in Fort Lauderdale, which you can see actually in the background here. I got my picture of that set up, etc. So thank you very much. And it sounds like our p-values are all less than 0.05, so that sounds statistically cool. We're good. We're significant. All right, everybody. Thank you. That's enough. Okay. We'll see you. Good afternoon now, and bless you all, and stay healthy. Okay. Bye-bye.
Take care, everyone.
Thank you.
I'm signing off.